Except I'm gonna wipe my eyes. Okay. Here we are in our, let's see, our 6th voting session of the session. And we will start this session. This is the HGO Committee with House Bill 643. Aaron?
Remember, these are the withdrawals, the first few.
Oh, I always forget that. If I didn't forget that, you guys would be disappointed. Is everybody okay withdrawing the first 4 bills, 643, 790 Delegate Kerr, 1074 Delegate Pena-Melnick? Yeah. Is that 4? That looks like 3. Oh, I missed one.
There's 4.
1377 Delegate Prettyman. Shall we allow them to withdraw? All those in favor say aye. All those opposed, please raise your hand in the panel that I'm about to open so that I see it. I see no hands. It passes unanimously, so all those bills will be withdrawn. House Bill 129, Aaron and Jocelyn. Oh, sorry, Aaron and Delegate Pena-Melnick.
House Bill 129 requires MDH in awarding grants from the Behavioral Health Crisis Response Grant Program to require that proposals include response standards that prioritize mobile crisis teams over law enforcement when responding to individuals in crisis. Each public safety answering point must develop a written policy on the procedures to be followed when a call is received that involves an individual suffering an active mental health crisis. The policy must include the procedures to triage a call involving an individual suffering an active mental health crisis, the resources that are available for dispatch, and the procedures for making a dispatch decision. There is a reprint of the bill on pages 1 through 7 of your packet that reflects the amendment adopted in the Public Health Subcommittee. Amendment number 1 strikes language that would require grant proposals to contain response standards that minimize law enforcement and instead require the grant proposals to contain response standards that prioritize mobile crisis teams over law enforcement when responding to individuals in crisis. The amendments also require the public safety answering points policy to include training for applicable staff on implementing the procedures.
Delegate Pena-Melnick.
Thank you, Chairman. So the Maryland Behavioral Health Crisis Response Grant Program exists already. We passed a bill, we created it. It funds local government to help establish and expand local crisis services. It has in FY year 2022, $5 million, and is going to increase by 10 million every year until 2025. What this bill does, basically, it's what Aaron just said, where it adds the language that in awarding grants under this section, the department shall require that proposals contain response that prioritize mobile crisis units over law enforcement. It does not limit law enforcement involvement at all. And basically the other thing that it does is that it says that each public safety answering point will be responsible for developing a policy on the procedures to triage a call involving an individual with mental health. So they will have to create a written plan on how to deal with a call like that. If you were to ask, and I thank my colleague Sip Saab for helping me out, who do you dispatch when someone is responding, you know, where you get that training? I found out that the training on who to dispatch and how to respond is part of the existing emergency dispatch protocol system funded by 911 Trust Fund, and I found it in the fiscal note as well. So the bill does not limit local jurisdictions. Everyone can basically have their own plan, whatever they think that mobile crisis unit should look like. There are existing recognized best practices, and that's all basically. And the bill was not unanimous. It was actually party line, and I moved the amendments.
Second. Is there any discussion? I see Delegate Shalega's hand is up. We'll start with you.
Thanks. I just looked at the Senate bill and it passed unanimously. Did our language concur with theirs? Their language took out minimize law enforcement and put prioritize.
It matches with the addition of the House bill has those training standards for the written policies for the public safety answering points.
The training standards, Aaron?
Yeah, so we have additional language about providing training, but the language about prioritizing mobile health crisis is identical to the Senate bill.
Okay, thank you.
Thank you for the question, Delegate Krebs. Great Chairman.
Yeah, on page 5. Oh,
Thank you.
are you going, Chairman, you want to go?
No, Delegate Krebs, I want you to go, but I was just daydreaming about how nice, how polite Delegate Shalega was and being very happy and feeling nostalgic. And so I got distracted.
Oh, is there something I don't know here? Okay, so on page 5, on line 17, it still talks under priorities about limiting the interaction of law enforcement for individuals in crisis. And you can get back to that, but I know we've had these grants in the past, and this is sort of following up, and our county has taken advantage of those grants. And I've been on the opioid policy group in our county for the last 4 or 5 years, and we've used these grants. But have we gotten any information back on the data from that was required? I think that's old language. Do we have anything back on what the outcomes have been for the grants that we've had in place before? Does anybody know? And let me tell you why I'm asking the question, because I mean, like I said, we had these grants at least the last 3 years, 4 years. And in our county, we were doing really well with the mobile crisis teams. However, during COVID, they stopped because they wouldn't let them out. And the police officers had to go and respond. Like for almost 2 years, I think, we didn't have them going out. So I don't know how something like that would affect our data on these outcomes that are supposed to be in these reports. But keep in mind that we like literally stopped doing it. And then in line, so I'm looking to see if there's any data that we've looked at. And then secondly, on line 17, is still one of the priorities is limiting the interaction of law enforcement. And in the case that we had in the last 2 years, we done it because of COVID. I mean, we didn't send the teams out. So how would we adjust for that?
I know some jurisdictions and, were able to send their mobile crisis units. Some did not. So this bill does not change any of that. You could basically develop your own protocols and have whatever teams you want in place. I did get an email today from Daniel Rabbit from the Behavioral Health Services in Baltimore that said that all mobile crisis response teams need to have a strong partnership with law enforcement. Sometimes police need to secure an area before a team goes in. Sometimes they need to intervene if things get out of hand, and they should always be in close contact. And then he attached a protocol that is used when involving law enforcement, and there's 5 different scenarios. So it's really up to the, up to the counties. We did get a letter from the Maryland Association of Counties that supported with amendments, and that's why we changed the language to do, the language that is in here that includes we got rid of minimized law enforcement interaction because Maryland Association of County did not want it. But their letter was actually positive, and we did get that as part of the testimony regarding this bill.
So in the situation that you just mentioned, from the guy that would that have counted as an interaction with law enforcement when they secured the perimeter? Because it doesn't really define that.
I would imagine that it would, because there are 5 like standards that he sent that are acceptable best practices. So that's part of it, is to, have it at some point, whether you're on the phone, like one of the scenarios that he sent, the police are on the phone, right? Or whether you secure the area, there are different ways to get involved. It does is not prescriptive.
And I think we were one of the first counties in the state, Carroll County, to implement mobile crisis teams. But I have a call into my sheriff because I want to make sure that this language that the new language does not tie our hands with what we're already doing. So I'm going to vote no, just because I want to wait for the call. I texted him this morning. He hasn't gotten back to me, but I may vote yes on the floor just because I want to make sure it doesn't hurt us from what we're already trying to do. I
Do you
believe
want
in-
me, Delegate Chris, will you like me to hold it until you find out if the chairman would like me to do that? For you
It's
to
up
find
it's
out
up
that
to you.
answer?
It's up to you guys.
I can hold it until you find that out. That's okay.
Because I am all about what we're trying to accomplish. I just want to make sure we're
Right.
not tying our hands.
Not a problem, but the information we heard in committee, that does not tie the hand, because it's not prescripted. It leaves it up to each county to develop their own protocol as well. So I will hold it, if it's okay with the chairman, until you find that answer. We're
Yeah,
not in a rush.
And law enforcement did not weigh in. That's what you put up the red flag, why they didn't weigh in. Yes, and I wish they had.
Yeah.
But thank you, if you
My
don't
pleasure.
mind.
And it did pass the Senate, right, Erin? I mean, it did pass the Senate, and it was
Yes.
unanimous as
So
well.
we had-
Just-
This committee has possession of the Senate bill. Just to clarify, Delegate Krebs, the line that you read from is the definition of mobile crisis team. And that definition is just for purposes of a mobile crisis team applying for grants under this bill.
Well, I was looking at where it says priorities. It says priorities limited in the.
Oh, I thought you were reading from page 5.
Line 17.
Yeah, so that's, if you see, if you look up the page
Mhm.
6, it's the definition of mobile crisis team.
Yeah, I see. But it then just tells what the priorities are. I get it. Yep. It's up to how you want to handle it. Thank you.
I'll hold it, and you can make the call.
Okay. Let me say that we should be prepared when we start holding bills to think that there may have to be extra voting sessions, because we have a whole lot of stuff to get through the process, and I know everybody wants their bills through before crossover. So, and this is not intended to be punitive, it's just reality. We may be voting more than once a week, as awkward as it is to try to fit this into our schedules, as hard as they already are. So just be aware that this would have happened whether we held this bill or not. It's just where we are in session.
This bill is also jointly assigned with judiciary, so it needs to go to judiciary as well.
Before it goes to the floor.
Correct.
You know, for that reason, I think I would like to have the vote today, if you don't mind. Delegate Krebs, are you okay voting one way today or
I will
not?
tell you,
voting?
I'll tell you what I'll do. I'll vote yes if you allow me. If I get a bad answer, then I can vote no if I don't like it.
You mean on
That's
the
okay.
floor? You mean on the
Yes, I mean,
floor?
I'm gonna, I mean, I like this idea. I just want to make sure it's not tying our hands of what we're already doing. So I will vote yes today, but I get the prerogative of it later.
Thank you.
That's a good deal, because I truly believe that you're going to be okay with the bill. But I'd like you to have the time to feel good about it. Okay. So with that, you probably made a motion to,
I have Delegate Chisholm, Chairman, has a question.
oh, Delegate Chisholm, I'm sorry.
Thank you, Madam Chair. And just to piggyback on this, we actually had Jen Corbin in today, and I know that Delegate Bagnell knows the incredible work that the crisis response team does here in Anne Arundel. And it's my fault because I didn't like this bill on Tuesday night or Monday whenever we heard it. I wanted to reach out to her because I don't want their hands to be tied as well. But my big question is, don't all these counties already have this plan and these procedures put in place? And kind of my point on Monday night was, this all sounds great, but none of this happens in black and white. It just doesn't. Every single situation is different. I understand the intent to decriminalize, but this is nobody expected what we're going through this week or what happened last year. It's tough to predict these things. And I think that most of them already have in good practice these procedures put in place. My goal always is to protect the life of the innocent. And I fear we're going to put some innocent people in danger if we continue down this road of where we're going to tie the hands of law enforcement or the people like Jen Corbin who do an outstanding job of making sure to keep the public safe. And so I would vote no on this bill, hoping that it ends up being okay, but that's just my opinion and my thought process on it.
That's fine. And I'm going to address your comments because I think it's important. This is not about decriminalizing anything. This is about de-escalating crisis. And if police need to be involved and the plans that a county has call for police to be involved, in some way, then following their plans is what this bill requires to put you in line for grants. It doesn't require you to do it. It just says we're putting a priority on the grants to counties that have a plan in place, and they're not specifying what needs to be in the plan. But this is in no way about decriminalizing anything. It's about trying to get, like we do in our committee, to a good result without making things worse by not knowing how to deal with situations like we deal with them in a nice way in this committee. So I want to remove the word decriminalization from this conversation, because I think that you're thinking about other things that this is not.
Well, and I may be wrong, Madam Chair, and I appreciate that, but I think that was the term that the sponsor of the bill used in part of her testimony, was she wanted to decriminalize. So it's stuck in my head.
Fair.
Thank you.
If I may, I also represent Prince George's and Anne Arundel, and I know that our crisis mobile unit got an award last year and about the amazing work they do. And actually, we received a letter of support from the county, from Anne Arundel, for this bill, especially when we got rid of the language that Mako objected to. And as you know, we amended the bill to address those concerns. My pleasure.
Okay, and however you vote, we'll love you regardless.
Right.
Okay,
And vice versa.
thank you. With that, all those in favor of the
Delegate
amendment-
Riley has a question,
Oh,
Chairman.
I'm sorry, Delegate Riley. I keep not looking in the correct corner. Go ahead.
That's okay, sorry. Yeah, I was gonna say, I too will remain no on this, as I was in subcommittee, and for a couple of different reasons, but as we're talking, I think not only, this could be dangerous to the person that is calling for help, but also, the innocents that are around, but also, are we putting a lot of pressure on the dispatchers, to kind of make this decision? Okay, do I call a social worker? Do I call a mental health provider, or do I call the police? So I have that little bit of concern too. So the bill as a whole just makes me uncomfortable. So I just, but, I know we talked about the law enforcement part, but also I think there's a big issue on the other end of who's actually taking the phone call. So I would just hope that the body would consider that as well. Thank you.
Thank you. Delegate Johnson.
Thank you, Madam Chair. Isn't that the whole reason for the counties coming up with their plan? So there will be a standard SOP for that county on exactly how a dispatcher will handle that, and when and if the law enforcement will
That
go,
is-
and what exactly they do.
Yeah, that's correct, Delegate Johnson. They have had incidents where people have actually died, the person that has been in crisis because it has escalated the crisis. And this basically, as the chairman said, is to de-escalate it, to send the right team. And if they have basically a written plan, and if you look at the bill reprint page 6 and look at line 25, it says each public safety answering point, which will be the people we're talking about, shall develop a written policy on the procedures to be followed by the public safety answering point when a call is received that involves an individual suffering an active mental health crisis. The written policy developed under this paragraph shall include the procedures to triage a call involving an individual suffering an active mental health crisis. And it's important to keep in mind here that the departments will decide what that protocol is. This bill is not telling the departments what protocol they should, get, but it gives them a little guidance here. And it says it should include the resources that are available for dispatch, the procedures for making a dispatch decision, and training for applicable staff on implementing the procedures. So it does, you're absolutely right. It gives them some guidance because they have none right now.
Thank you. Thank you.
My pleasure.
I see Delegate Sample Hughes, then Delegate Hill.
Thank you, Madam Chair. I just wanted to acknowledge Delegate Riley's concern. I'll be honest with you, I had the exact same concerns early on when I heard the bill, but then I spoke with the bill sponsor and shared with her those concerns, and that's where that training piece came a little tighter, or at least had a little bit more teeth in it. And with that being said, I thought that was beneficial. The second thing is that I had opportunity to speak with dispatchers and just wanted to hear from them what their thoughts were. And hearing also that they have found so many mental health crisis situations that they're involved in and trying to figure out what to do with on a regular basis, more so sometimes instead of our traditional 911 calls. And so after hearing that and then addressing that training piece, it brought my mind to a different understanding. So I just wanted to give you that. I was kind of on the same fence, but that was the information that helped.
Thank you so much.
Delegate Hill. You're muted.
Thank you. Thank you. Okay. So since we're having the conversation, this is my understanding of what part of the problem has been. A lot of counties have set up, crisis intervention teams, and they put mental health specialists and police together, and they send them out when they're available, because most of the time they're not 24/7, to whatever comes up that seems to be applicable. What I think this bill does, it now provides them with, it directs them to, now that they've had some experience, to sit down and think about, given their experience and all that they've learned, which types of calls require the team, which types of calls should be answered by the mental health professionals alone, which calls should be preceded by police and only have the mental health professionals come in as a backup. And it allows them and requires that they now be thoughtful in coming up with true protocols based on the variety of calls that they get, to try and make sure that it's not hit or miss, but that we're giving the right response the overwhelming majority of the time. And that everybody from the 911 specialist all the way down to the last person to arrive at the scene is clear, and that they also talk about when what they thought the situation was going to be is found to be different, or when it begins to escalate, who gets called in. And anytime you can give someone dealing with a crisis sort of a protocol to follow that everyone is aligned with and understands what happens next, it makes for safer outcomes. And that's all I wanted to add.
Thank you.
Delegate Krebs.
I know you don't like two bites at the apple, but I just heard back from my sheriff and I just want to tell you what he wrote. And first I'll read you the paragraph. And I think we're on the same page with this, but it says here, in awarding grants under this section, that departments shall require that the proposals contain response standards that prioritize mobile crisis units over law enforcement when responding. He basically said, this is a perfect world build, and whether or not you like it, law enforcement has to be the first responder with that person on a call, because who in their right mind that isn't law enforcement would walk into a situation knowing the chances are they could be assaulted or killed. I know on our mobile crisis, we send law enforcement with them, and so I think he's right. And some social worker is not going to go to somebody's house that's in a crisis without somebody there that could protect them. So I want to make sure that the way we've written this, that this would include, I mean, absolutely you want the crisis units to go out, but you want to make sure law enforcement can participate as well. It would not penalize them from having that response, because I wouldn't want to go out into some unknown situation where you have no protection. So how would you interpret that sentence? Would that include that law enforcement could go as well?
I would respond that if MACO supports it, then they feel that they have the power to do what they need to do.
Well, MACO is not law enforcement. Let me just, they're not law.
MACO is local governments, and local governments include being concerned that their police can do what they need to do and they keep their people safe. I mean, I was in MACO for years when I was in local government. And we consult with the county executive, who also usually has a person. And we make sure that anything we vote on as a member is something that will work in our county. And MACO is not shy about bringing amendments or telling us they don't like something. And they have good people, including their offices of law, to give them help when they need it. So I have great confidence that if MACO's good with this, then it should be okay with the counties and it should work in the different counties.
If I may also add, Chairman, if it's okay.
Please.
I'd like to reread again Mr. Daniel Roberts from the Behavioral Health Services in Baltimore. He says that all mobile crisis response teams need to have a strong partnership with law enforcement. Sometimes police need to secure an area before a team goes in. Sometimes they need to intervene if things get out of hand, and they should always be in close contact. I have attached one example of a protocol used for when to involve law enforcement in behavioral health crisis response reference. So that is basically the practice that is accepted. And it says here, level 1, law enforcement leads with mobile crisis team accompanying or following behind. The team must heed police instructions and respond as the scene is deemed safe for entry. And this is a level that indicates that the situations are too dangerous to be deployed without the environment first being secured by law enforcement. Then you have level 2, mobile crisis team leads with law enforcement in the background or following behind, but on the scene. It says calls, reports any of the following. If it's a history of aggression, recent act of aggression or self-injury, that's the protocol used. Level 3, mobile crisis team lifeline, law enforcement on standby by phone. And this is in a case where it's a clinical situation that the person is in the hospital, where they're contained as well. So there are different scenarios that is accepted, but law enforcement is always present.
And I don't disagree with you. Anything you just said, I just say the way I read this, it doesn't necessarily say that. That's all I'm saying. I agree 100% with what you said. I just wish the words allowed for that they could be in conjunction, and it would make it more clear. But
yeah, I think that the word says prioritize, but it doesn't say prohibit. So to me, prioritize means that we all know that the purpose why we want this intervention dealt this way is because oftentimes, we have a lot of people, like 90% of the people in jail are really people that shouldn't be in the jails. They, someone that is homeless, someone that has a drug problem, or, is having a mental crisis. So we all know that from being on this committee and for reading stuff. But I really think that the reason why we need this, and it says prioritize, is just because the objective here is to de-escalate the crisis and to focus on the mental health crisis and to provide the care that the person really needs to address that problem. But it doesn't say prohibit and we got rid of the word minimize as well. So I think that it does what you want it to do as well.
would it be acceptable to change one word and say prioritize mobile crisis units partnering with law enforcement when responding to individual crisis? Instead of, I don't know, it's just understand there's a partnership. I don't know. I don't want to keep pushing this, but I'm a little uncomfortable with it.
Yeah. I think I'm going to just leave it like that because we have had the hearing, went to subcommittee. It passed the Senate unanimous as well. And we're like, it's a difference of a word, but I think that prioritizing it doesn't limit and does not mandate as well.
Doug Penny-Malik, it was party line in the Senate.
Party line?
It was party line in the Senate.
Oh, it was not unanimous in subcommittee? No.
It wasn't unanimous in your subcommittee either.
Okay. No, I'm not talking about my subcommittee. In the Senate, it was party line?
In the committee.
I can't hear you. You're muted.
Oh, sorry. I'm going to double check, but I'm almost 100% sure it was party line in the Senate.
Okay.
Yeah, if you can check, Aaron, because I think I clicked on it and I was surprised it was unanimous. So I must have clicked on the wrong bill.
Okay, let me.
Yeah, I have unanimous as well, though.
Okay,
actually,
then,
that's what I heard in subcommittee, but maybe they were wrong. But we should check.
I will double.
Unanimous in the Senate. It was unanimous in the Senate.
It was
It
what?
was.
It was unanimous.
Okay, yes, sorry, my mistake.
It's okay. It happens. We want to get it right.
So it was unanimous in the Senate. So your senator voted for it.
Write
For
that
what
down.
that's worth.
One time I got it right and Aaron didn't. It'll be an only.
That's right, because she's always on the ball.
She is.
Okay, she gave me the right information to her subcommittee chair, so it's good.
Okay, well, it doesn't hurt to double check. Okay, Delegate Bagnell, last bite at the apple here.
Thank you. I'm just trying to sort of double down and drill down on where our concerns are. Do we have, and I'm sure it's in the bill, I just haven't been able to put my eyes on it, the definition of mobile crisis teams, is that defined anywhere in code?
It
'Cause I
is.
think
It's defined
in this bill.
actually. And is it on page 2?
No, it is.
1 second.
Page 5.
1 minute. Oh, yes, it's on page 5, line 6G. It says mobile crisis team means a team established, thank you, Aaron, by the local behavioral health authority that, one, on line 8, operates 24 hours a day and 7 days a week to provide assessments, crisis intervention, stabilization, follow-up, and referral to urgent care, and to arrange appointments for individuals to obtain behavioral health services. Line 11, 2, incorporates nationally recognized standards and best practices and prioritizes providing connection to services and coordinating patient follow-up, including peer support and family support services after stabilization, serving all members of the immediate community with cultural competency and appropriate language access, and limiting the interaction of law enforcement with individual in crisis. So it says limiting, not prohibiting. So that's the definition.
Perfect. Thank you so much. Because I think that the challenge is we're looking at prioritizing mobile crisis units over law enforcement alone, but we just don't have that alone. It's sort of implied. So I appreciate the definition, because there's nothing that limits the involvement of law enforcement in that team.
Okay,
Thank
so
you.
are we all ready to vote on the amendments? All those in favor say aye. All those opposed, no. Please raise your hand in the panel, and I'm seriously looking because I'm expecting a few no's here.
Are you meaning amended bill or amendments?
The amendments. We're on the amendments right now. We'll get to the bill later. I see no hands. Delegate Krebs, your hand went down. Is that correct? Excellent. Okay, I don't want to make a mistake and get your vote wrong. The amendment passes unanimously. Is there a motion?
I move
the bill as amended.
a bill as amended, please.
Second.
Discussion on the bill as amended? Delegate Krebs, really?
Listen, I'm sorry, I'm just getting this information from my sheriff. He just texted me again. And he
Okay.
said, I'm not sure how this can be done if you don't have 24/7, 365-day-a-year crisis response workers to navigate the nearly 600 calls my office receives annually for people in mental health crisis. Not to mention an abundance of these calls, if not 90% of them, are people who are a danger to themselves and anyone around them, which would require law enforcement. If you talk to the behavioral health people that respond to these calls, they simply don't want to go in until law enforcement has deemed it safe. Again, I am not against the bill. It's just how it's worded. It seems like the way these grants are going to, we use these grants, and that's why I'm really careful about it. We want to make sure that we're not excluding law enforcement, and it doesn't say that. And I'm worried about it because in these smaller counties, we don't have 24/7 mobile crisis. We don't have 365. And so the data might come out and say that we're, not prioritized when we do, when we're able to. So it's just a matter of just what we're telling the data, the grant people to prioritize. And that's my only concern. But I understand, I want to get the bill passed, but it's just a problem for me and my sheriff as the comments that I've been getting. So I'm trying to do my homework with my county. Please respect that.
I'm respecting that. I don't see any other hands up. I thought I did. Okay. I will add that I would be surprised if any county has 365 24/7. I would be. I don't think they do, but I could be wrong. I did not do the homework on that. With that, we had a move and a second. No further discussion. Is there, all those in favor say aye, and all those opposed, please put your hands up. I see Kipke, I see Riley, I see Shalega, I see Morgan, Chisholm, and Krebs. Okay, did I leave anyone out? Okay, those are the no votes. Did my staff get the no votes so that it's correct?
So
Madam
Delegate
Chair,
Sipsa,
I was a negative also.
Oh, I'm sorry, Sid. Delegate Saab, I don't know why I didn't see your hand, but you're up there now.
I was a little bit late.
Okay. Makes a nice change when it's not me. So
No,
thank
it's
you for that. Okay. Okay, Delegate Saab as well. Have you guys got that, Richard? Okay, I saw the thumb. Okay, that bill passes, not unanimously. House Bill 229, Lisa.
As introduced, this bill altered the definition of maintenance injectable medication to include a medication that is administered by injection other than intravenously and treats a sexually transmitted infection and is not a vaccine. There are amendments on page 8 of your packet. Amendment number 1 is technical, and amendments 2 and 3 define injectable medication for treatment of a sexually transmitted infection for the purposes of authorizing pharmacists to administer the medications and requiring certain carriers and Medicaid to provide coverage for the administration of the medication by the pharmacist, as is currently done for maintenance injectable medications. The amendments also provide that to the extent determined appropriate by the Board of Pharmacy, the regulations established for the administration of maintenance injectables by a pharmacist shall be the same regulations for administration of injectable medications for treatment of sexually transmitted infections by a pharmacist.
Delegate Penyelnik.
Delegate Kelly.
Delegate Kelly. Thank you.
No problem. So this bill came to subcommittee. It was actually an amendment that was put on in the Senate side on a bill last year we had that we passed, I believe unanimously. And we did not take that amendment last year. It came back as a standalone bill this year. It's already passed the Senate. The amendment we put on, while it is not in the Senate version, has been agreed to by the Senate sponsor. It addresses the concerns that were raised by the insurance carriers just about the statutory language that was used in defining the program. But what the bill does with the amendment is allow pharmacists to do the injections for syphilis and gonorrhea. It's going to help us with these really increased STI infections in the state, and it did pass unanimously, as did the amendment. Move the amendment.
Is there a second?
Second.
Is there discussion on the amendments? Seeing none, all those in favor say aye. All those opposed, no. Please raise your hand. I see no hands.
Move the bill is amended.
Second.
Discussion. All those in favor say aye. All those opposed, no. Raise your hand in the panel. Seeing no hands, the bill passes unanimously. House Bill 275, Aaron and Delegate Penyelnik.
House Bill 275 establishes and expands several prohibitions and requirements that relate to the manufacture, sale, and distribution for sale or use in the state of specified products that contain intentionally added PFAS chemicals. There is a reprint in your packet on there are amendments in your packet on pages 13 to 16. The amendments add a definition of terminal. They require MDH to adopt regulations. They extend the implementation date for the prohibition on the use of Class B firefighting foam containing PFAS to January 1st, 2024. The amendments authorize the use of firefighting foam containing PFAS on or before September 30th, 2024 at an airport, port, refinery, or chemical plant, on or before December 31st, 2027 at a terminal, and on or before any date specified in federal law if being used by a person who is required to use Class B firefighting foam. The amendment requires MDH to purchase certain firefighting foam from a fire department on request, requires MDH to dispose of firefighting foam in a certain manner, and requires the governor to include funding in fiscal 2024 to the department for the purpose of purchasing firefighting foam. The amendment extends the implementation date for the prohibitions related to PFAS chemicals in rugs or carpets and food packages to just January 1st, 2024, and alters the definition of food package and PFAS chemicals.
Delegate Penny-Melnick.
Thank you, Chairman. So this bill, the subcommittee met twice. We have very long discussions, brought everyone to the table, allow everyone to speak, whether you're a manufacturer or a retailer. The bill, I believe, Erin, correct me if I'm wrong, it passed the subcommittee in the Senate unanimously.
Correct.
And it passed our committee in the House unanimously. We were able to negotiate with the retailers, the manufacturer, negotiate and compromise on the language. And we have the buyback provision to address the MACO concerns. So I move the amendments.
Second.
Thank you. Is there any discussion on this bill, on these amendments? Delegate Kipke.
Thank you, Madam Chairman. On all votes and actions regarding this bill, I need to be marked as excused. Thank you.
We will mark you as excused. You got that, Richard? Good. I'm going to ask everybody who is a voting member to have your face on camera. I don't think we can have you coming in and out if you're voting on bills. So please remain on camera for the voting session. Delegate Chisholm.
Thank you, Madam Chair. I remember the retailers being okay with it after the amendments. And MACO was okay. Was everybody satisfied with the amendments once the amendments were?
Everyone that came to the meetings were, I know that W.L. Gore and Associates were opposing it, but now they are neutral.
Okay.
I would say most of the people are neutral. Some people we didn't hear back from after it passed the subcommittee in the Senate and here, but I would say that there were a lot of people at the table, distributors, manufacturers, retailers, and very outspoken, and now everyone is fine with it. It was a really great process.
Okay, thank you very much.
My
That's
pleasure.
Okay, any further discussion? I'm sorry, I'm getting tangled up in whether I am or am not muted. Delegate Shalega.
I'm going to discuss, are we on the bill or amendments?
The amendments, and I was going to call the roll on the amendment.
Okay, I'll wait until we're on the bill.
Fine. All those in favor of the amendments, please say aye. All those opposed, please raise your hand in the panel. I see no hands. The amendment passes unanimously. Delegate Shalega. Wait, we need to move the bill, Delegate Penny-Melnick.
I move the bill as amended, Chairman.
Second.
Delegate Shalega.
Thanks, Madam Chair. I do want to thank the chair of the subcommittee, Delegate Penny-Melnick, sorry. She did work very hard to bring all the people together. I do not love this bill, but I am voting for it because of the hard work and the compromises that were made on all sides. I do want to say that we had a PFAS bill last year and now they're back this year. You know, this is like how many bites of the apple. We need PFAS firefighting foam to put out fires of gasoline and some other products. Nobody wants to harm the environment. No one wants dirty water, but I just want to say thank you for your hard work. And, you know, I hope we don't see it again next year. Thank you.
Thank you for your questions, because your questions helped everyone come to the table, and I really appreciate it. I mean, I appreciate the whole subcommittee.
Okay, I see no other hands. Thank you, Delegate Shalega. All those in favor of this bill, please say aye. All those opposed, please raise your hand. I see no hands. This bill passes unanimously.
Thank you.
House Bill 378, Erin, Delegate Penny-Melnick.
House Bill 378 requires the Maryland Healthcare Commission to convene a work group to study and make recommendations to improve palliative care services in the state. The work group must include representatives of hospice and palliative care providers, healthcare facilities, patient advocacy groups, and health insurers. The work group must submit a final report by November 1st, 2023, including the need for any legislative initiatives to the governor and the General Assembly. There are no amendments.
Would you like to talk about this bill, Delegate
I just want to
Pena?
say, woof, I finally get an easy bill. It was unanimous.
Would you
I
move that
moved the
easy bill
bill.
for us? Would you move that bill, please?
Yes, I moved the bill.
Second.
Is there any discussion on this bill? Seeing none, all those in favor say aye. All those opposed, no. Please raise your hand in the panel. This bill, I see no hands. This bill passes unanimously. House Bill 353. Aaron and Delegate Rosenberg, and hold your breath, Delegate Landis.
I'm almost fainting.
The bill increases the maximum amount of user fees the Maryland Healthcare Commission may assess on hospitals, nursing homes, payers, and healthcare practitioners from 16 million to 20 million. There are no amendments, and it was in Government Operations and Health Facilities Subcommittee.
Delegate Rosenberg.
Thank you, Madam Chair. The cap for this commission has been 16 million since FY 2017. We continue to give it additional responsibility. The bill just before this would provide for a work group on palliative care. We have another bill before us on assisted living. So therefore, and in light of the testimony that was presented by the sponsor, there were no amendments, and I will say the vote in committee was 7-3. Vote in subcommittee was 7-3, and the vote on the Senate cross file was 30-16. So I would move favorable.
Second.
Second.
Is there any discussion? I see Delegate Shalega's hand first, followed by Delegate Krebs.
Thank you, Madam Chair. And we have 2 fee increases this year. It's unfortunate that we have 2 fee increases on the same people, but I would encourage all of you to look at this document that you got and look at the last page of the document, which talks about one of the major initiatives driving budget increases. It is 1, 2, 3, 4, 5, 6, 7 bills this year. So, every year we continue to make work groups and study groups. And, sometimes it's because we love our colleagues and we want them to have a bill and feel good about themselves. But ultimately, it's leading to increases in costs because it costs money to do these things. So that's why I'm voting against it. I think it's too much. And I think it's got nursing home fee increases. And these are folks that are really, really not doing well this year. So again, if it hadn't been coupled by the bill that we're going to vote in, two more bills, that is another fee increase largely on the same people. But I encourage you to look at this and think about work groups. Thank you.
Thank you, Delegate Shalega. Delegate Krebs.
Thank you. And I'm not sure if the committee took into account the MedChi testimony and the Board of Physicians testimony. Was that considered?
Yes.
And what was the feedback?
Well, I think we feel that overall, this is how we've financed the allocation of the cost is how we have historically done it for this commission. And there, in many instances, there is a savings that results or an enhancement of the care that is provided as a result of the studies and work groups that we mandate for this commission to conduct. So
well, and one of their arguments is that used to be a nexus between the fee and what they got out of it, but now the nexus says most of the projects that the Maryland Healthcare Commission puts on does not benefit the people that pay the fee anymore. They benefit the consumer of healthcare as much as facilities and providers. So what their argument is, and I don't disagree with them on a lot of the things that Delegate Shaliga mentioned, and some of the things in the past, like the prescription drug Affordability Board. They were supposed to find their own way to pay for themselves. They've been in effect for what, 3 years now? They've already been forwarded $1 million out of here, and they still haven't put a funding mechanism in place since 3 years ago when we were supposed to have a funding mechanism. And it's coming out of this, all these people that are being assessed, which is our assisted livings, our nursing homes, our physicians, all of the boards pay 30, I don't know if you read the fiscal note, but all of the boards, part of their fees go toward funding this. And they're saying the nexus isn't there on these things anymore. So my question is, with a huge budget surplus that we seem to have this year, maybe, because of some of the bills that we're passing that really don't have a nexus with who's paying it, would it be better that it gets, in the last couple of years, there has been shortages and the governor has funded it out of the general fund. Why would we not maybe want to move in that direction versus raising these fees when there's not necessarily, there's no nexus to me for the Prescription Drug Affordability Board to, the providers. Why doesn't it go to who it's going to benefit? So that's my question. Did you consider just making it a mandated appropriation out of the general fund?
Well, I know that the governor does not appreciate mandated appropritations.
Well, I don't think all of our healthcare providers and assisted livings appreciate getting a fee either. You know what I'm saying? Ongoing. But anyway, their arguments, the nexus isn't there on some of these boards and commissions that now they're being asked. That's how it's being paid for. And I sort of, after reading it, I sort of agree with them.
Well, we make a judgment on this bill and we make a judgment on every other bill that comes before us, requiring the commission to make a study that it is sound healthcare policy to know more by virtue of the study than we would without it. And this is how this commission has been funded over the years, and it should remain that way. And the commission is seeking this increase. So
I don't think they care who pays for it, but I think just because we've always done something a certain way doesn't mean we have to keep doing it that way. But I just don't like, if they need the money, fine. It'd just be nice to sort of make the users who are going to benefit from these studies pay for it versus the same people all the time. And again, as it was mentioned, it's the assisted livings, it's our nursing homes, it's every single board and commission pay 30% of this, which is it's a lot on our nurses, our nurse practitioners. Every single board and every single licensee is going to have an increase. But that's just my say on it. Thank you.
Thank you, Delegate Krebs. Delegate Kaiser.
Thank you, Madam Chair. I have a question or two for the subcommittee chair. The first thing, I certainly didn't vote for this bill to make any particular delegate feel good. I don't think anyone did. My understanding is that both for this bill and the other bill, Delegate Rosenberg, we've given more responsibilities to these commissions without increasing their funding. And so, I mean, that's the first simple question. But then when I hear that it should come out of the general fund, I don't think that's sustainable. It seems to me that the commission is trying to be responsible to say, you're telling us to do more, and we need the ability to have more funds to be able to do that, and in a sustainable way. Is that the argument that they were making?
Yes, it is.
Thank you for that clarification.
Thank you for the question.
Delegate Cullison.
Thank you, Madam Chair. And I guess I just wanted to say that I have a different perspective on the value of the work that MHCC does to our agencies, to our programs, to our and to our consumers. I mean, I know from an insurance standpoint, just this year alone, I've charged them with like 4 different things that are going to make a difference for real people. So, and I think it's true that we continue to ask them to do more. Next year, be happy to entertain different ways of funding it. But I think it's really important to understand that I believe there is a nexus directly between the work that they do and the benefit to our residents in Maryland. And with the Prescription Drug Affordability Board, they did actually come up with a way to fund themselves after being given no resources to start with, except that the MHCC, in its generosity, said, we really want, this is really important work and we want this to proceed. But that bill initially on how it was going to be funded was vetoed. So, I mean, we have, it's not like work hasn't been done on how to fund that board, but not sure that we've gotten completely there then. But I just want to make sure that, in my role, I see the great value of the MHCC and the work that it's really good work that they do.
Delegate Banderi.
Well, thank you, Madam Chair. I do 100% support that MHCC is providing advanced funding for the Prescription Drug Affordability Board, and this is a very good bill.
Okay. I just want to say that I got a text reminding me that MD-PCP, which actually I'm not sure what primary care provider, that's a program, is directly benefiting primary care docs, and that assisted living is not assessed, just to make sure that that's clear. That's just clarification. So with that, I see one more hand, Delegate Landis.
No, I got my sea legs back, right?
Yeah.
So I simply want to say that, yes, Chair Pendergrass, she did give this bill to me. And in doing so, she moved me out of my comfort zone, because I could have just sailed along and just continued in that mode. But what this has done, yes, it has made me feel good in a part of the committee. But at the same time, I've also learned a lot about the process and how things are done. So, and I've had many conversations with Ben Stephan, with the Maryland Healthcare Commission. So that's how you get things done, by building relationships with other people and giving opportunities to grow and to learn. So I appreciate the opportunity, Chair Pendergrass, and I will continue to serve this beloved state and Prince George's County in particular. So thank you to all of you for being so wonderful and so kind.
And we're not voting for the bill because we like you, Delegate Landis.
Absolutely.
We'll be voting for the bill or against the bill because of the merits. So don't take it personally.
Mm-hmm.
Okay, thank you, Delegate Landis. It's been a joy. And we still have 39 more days of session. Is there any further discussion? I think we already we moved the amendments. I assume there were amendments.
The bill does not have amendments.
No.
Then we must have moved the bill before we got into the discussion, right?
So moved. Yes, we did.
Second.
I would assume. Okay. All those in favor, please say aye. And all those opposed to the bill, please raise your hand so we can count you and accurately record you. Delegate Kipke is a no. Delegate Riley, Delegate Krebs, Delegate Shalega, and Delegate Chisholm. And I'm going to explain my vote to say how very pleased I am to vote.
You also forgot me again this time.
Why do I not see you?
I think me too. You forgot me.
Party line.
Party line.
Party line. Okay. Can we do it that way? I hope, staff, because I am missing people and I apologize. I don't know why. I don't know if maybe you're on page 2 until you open your mouth and then you pop to page 1. Maybe that's it. And my problem is I only see page 1 of what my screen is showing me. So I think that we're going to have that ongoing problem. I see Riley, Krebs, Chisholm, Morgan. Oh, there a hand popped up. Saab, your hand just popped up in the participant.
No, I had put it back down because I thought you're done.
Oh, okay.
But
All
it
right.
was up.
I can see it now. I can see all the hands there. Okay, it's a party vote. I want to say that without this commission, we would not have electronic health records and CRISP in the state. We would be so far behind technology. It would be sad. I hear somebody's background noise, and I know I had my phone ringing, so I apologize for that. But if we don't do the forward planning, then we will fall behind, and we need to make sure we're ahead of the curve on so many things.
I just want to make sure you know, my vote is not against the Healthcare Commission. They do a phenomenal work. My vote is against where we're taking the money from. So I just want to be clear about that. They do very good work.
Thank you. That's very good. I'm glad you explained that. Okay, Delegate Hill.
Just a piggyback on Delegate Krebs, my vote is not for taking more money from these groups. I think they make good points, but I don't think that we have done a job of coming up with an alternative funding source that can be relied upon.
Thank you to explain your vote. Well done. Thank you all. And with that, we will turn to House Bill 389. Lindsay.
This is the bill that implements the statutory recommendations of the Department of Legislative Services evaluation of the Minority Business Enterprise Program. There is a reprint of the bill showing amendments adopted in the Government Operations Subcommittee starting on page 17 of your packet. The amendments remove language from the bill that would have required agencies to consider prime contractors' past performance with respect to MBE contract goals in assessing responsibility of a bidder or offer. It also removes language that would have allowed graduated MBEs to maintain MBE certification if they serve as effective mentors to new MBEs. The amendments define industry type as the 6 procurement categories, and instead of requiring statewide goals by industry type, require industry type to be used in reporting for each unit to GOSBA and in GOSBA's summary report to BPW and the LPC. The amendments retain the option for procurement officers to assess liquidated damages and also require the new MBE ombudsman created under the bill to train procurement officers on the use of liquidated damages and require GOSBA to do a study on the use of liquidated damages, which is due back June 1st, 2024. There's a very small amendment change on page 27 relating to compliance assessments that require the names of all subcontractors to be included, not just MBEs. The amendments also, I'm on page 28 at this point on of your packets, require GOSBA and the Office of State Procurement in consultation with the Office of the Attorney General and BPW to adopt by regulation criteria to determine that a prime contractor has persistently failed to meet contract goals. The amendments also require GOSBA to refer prime contractors identified using that criteria to the Office of the Attorney General for debarment. This is debarment is discretionary by BPW and not to exceed 3 years. The amendments allow MBEs, DBEs, and SBEs that meet the definition of small business under the SBR program to participate without separate registration. Amendments add clarifying language that the ombudsman is assisting procurement officers in mediating disputes and requires the ombudsman to report on staffing levels. That report is due back December 1st, 2023. And finally, the amendments add a follow-up report from DLS due back December 1st, 2024.
Delegate Rosenberg.
Thank you, Madam Chair. The purpose of this bill and the amendments is to make the Minority Business Enterprise Program a better run program. Study done by DLS, Department of Legislative Services, to how can it work better so that we're not changing policy, we are enhancing that policy with a better series of recommendations. And in the amendment process and the review of the bill, the following agencies were involved: DGS, MDOT, Board of Public Works, GOSBA, and the Department of Legislative Services. The vote on the amendments and then on the full bill, the amended bill in the subcommittee, both unanimous. So I would move the amendments.
Is there a second?
Second.
Is there any discussion of this bill? Hearing no discussion, all those in favor say aye. All those opposed, no.
Oh, I'm sorry.
The ayes have it. It's unanimous. Go ahead.
Move the bill as amended.
Second.
Any discussion of the bill? All those in favor say aye. All those opposed, please raise your hand in the panel and I'll try to see you this time, Saab, if it's up there. Seeing no hands, this bill passes unanimously. We'll now move to House Bill 510. Aaron, Delegate Rosenberg.
House Bill 510 alters the maximum amount of user fees the HSCRC may assess on hospitals and related institutions from 16 million to the greater of 0.1% of the immediately preceding fiscal year's budgeted regulated gross hospital revenue or the largest cap amount determined during the immediately preceding 5 fiscal years. There is an amendment. There's actually a reprint of the bill in your packet on pages 38 to 41. This provides that the user fee methodology of the bill will sunset on June 30th, 2025, and provides that the user fee cap as of July 1st, 2025 may not exceed the average of the user fee amounts determined for fiscal years 2023, 2024, and 2025.
This bill is similar, obviously, to the Health Care Commission bill that we heard. The one difference, significant difference, is the amendment, which provides for a sunset 3 years from now. And in addition to the review of the commission that sunset would entail, remember that this commission is reviewed in the budget process by the budget committees, as is every agency. There is an annual report that is specifically to the subject matter committees, ourselves and finance. And then we often have a briefing on the work that the commission has done on the previous year. So sunset for the increase. We continue to provide work for the commission. And with that amendment, the amendment was adopted unanimously, and so was the bill as amended in the subcommittee. So I would move the amendment.
Is there a second?
Second.
Discussion on the amendment? All those in favor say aye. All those opposed, no. The ayes have it. I see no hands in the panel.
Move the
Rosenberg?
bill as amended.
Second.
Discussion? Hearing none. All those in favor say aye. All those opposed, no. Please raise your hand in the panel. Seeing no hands, the bill passes unanimously. House Bill 636. Lisa, Delegate Kelly.
This bill requires the Maryland Healthcare Commission to conduct a study regarding the quality of care provided by assisted living programs with 9 or fewer beds. The commission must work in consultation with the Office of Healthcare Quality, the Maryland Long-Term Care Ombudsman Program, Medicaid, the Governor's Workforce Development Board, and interested stakeholders. And the report is due by October 1st, 2023. There were no amendments.
Delegate Kelly.
Thank you, Madam Chairman. So I do really love the sponsor of this bill. However, I would have killed it if I thought there was no need for the study. This is a really important study. We have the stakeholders in the industry and the advocates on board, both saying this is something we need to look at. These smaller assisted livings really vary in quality. The Healthcare Commission is excited to do this study. And I think this is, really the first step for us understanding how we can improve quality of care in people's different living environments. We need to figure out how to invest more in assisted living. And we can't do that if we don't understand the quality of care at the smaller places, which are often the ones that the lower income communities are using. So really important, love it, and it passed unanimously. Move the bill.
Second.
Is there any discussion on the bill? All those in favor say aye. All those opposed, no. Please raise your hand. I see no hands in the panel. The bill passes unanimously. House Bill 684. Aaron, Delegate Peña-Melnick.
House Bill 684 prohibits MDH from limiting or restricting admission of a Medicaid recipient for inpatient care at a special psychiatric hospital or an acute general care hospital with separately identified inpatient psychiatric service unless MDH bases the limit or restriction on the medical necessity of the admission and establishes the limit or restriction through regulation. There were no amendments.
Did we skip 669?
We did. I go.
Okay. All right. It's okay.
Thank you for the heads up. We'll get there.
Okay. Thank you. So this bill we discussed and it was actually unanimous. So I move the bill.
Is there a second?
Second.
Any discussion? All those in favor say aye. Oh,
Delegate Shalega has a question.
Shalega, please ask your question.
Thank you. So I obviously was reading the bill and doing my homework as each one of you do. And I noticed on the fiscal note, it said we could lose some or all federal money and it could be significant. I remind me what we did, subcommittee chair. Did we talk about that?
We didn't talk about the fiscal note, but the fiscal note is 65,000. 1 second, am I in the wrong bill?
Yeah, I think
1
you're on the
minute,
wrong
is
bill.
684. Sorry, 1 second. I'm sorry.
This one was about average length of stay and what the impact, like a potential impact on average length of stay. So it's kind of an unknown, and we did invite MDH to this committee. They were there and did not speak up. This also was run through the Appropriations Committee, who gave approval to passing the bill.
Yeah, I mean, I love the idea, but like I said, when I was doing my homework for voting, I noticed that I had somehow missed it, but I don't know if we want to put some kind of backstop on it or, come back and look at it or something, but certainly we don't want to lose a significant, quote, their words, significant federal funding.
I think that, we know we can put in the bill, we did not discuss the impact. And I know that I'm reading the last sentence in the fiscal note. We do get 60% of federal funding. We can put a reporting to see what that is, like we usually do on some of the bills, if you like.
Yeah, I think we were so excited about we wanted to make sure we could deliver these services because there's such a need.
Yeah, the testimony was compelling.
It was, but we still don't want to end up losing federal funds because we jumped the gun or didn't keep an eye on that.
So we could do a reporting amendment. What do you think, Erin?
Yeah, what do you think, Erin? How can we make sure we're keeping an eye on this to make sure we aren't jeopardizing federal funds?
You could either do a report or, there's actually language where you could say if federal funds are risked. I'm not going to state it as eloquently, but you can do kind of like stopgap, like if you would lose federal funding, it wouldn't necessarily go into effect.
I don't think they
doing
can
the
know
amendment.
that. I don't think they can know that until they see what the average lengths of stay are, until it does
Right.
go into effect. I think it's only in hindsight that you can look and see what it does. So
You could do reports on what are the average lengths of stay. Maybe that would be a good thing to do.
What I was suggesting was maybe a report on the average length of stay and on the expenses, right? And if we're losing any money, if we can report on that.
And Delegate Bagnall has her hand up and it's her bill. She may have an answer for us.
Delegate Bagnall. Thank you, Delegate Schlega.
Thank you, Madam Chair.
I was looking at Delegate Krebs, who was next.
I think a report is a great idea because I did flag that actually with Shepherd Pratt as a concern, and they said their average stay is less than 20 days, but the average stay without access to the beds can be up to 30 days or even 45 in the outliers within an emergency department. So I think a report would actually reveal that this is not only a really good thing in terms of equity, but also is getting people into care and then back into long-term treatment or coordinated treatment at a faster rate.
Okay, we're going to come back to the conceptual amendment that we're going to have Erin draft to do some reporting, but let's go through other questions first, if you don't mind. Delegate Krebs, you're next, and then Delegate Hill.
Thank you. The department's testimony said the restriction, because they're using average length of stay, about the 30 days is average. So they're saying this restriction could reduce their flexibility in allowing additional days for certain persons that, maybe certain patients. And maybe as part of that reporting, I'd like to understand if somehow somebody needs more days and we're using this average, would it take away from the flexibility of the people that need it? So that sentence concerned me. So I don't know if that would be part of the conceptual amendment or not. Did this restriction?
I think that Delegate Bagnall Delegate Penny-Melnick needs to repeat the information that's in the bill or the amendment that has to do with they can't be limited based on anything except their medical needs. I can't quite remember the words, but there's a very clear protection from that, Delegate Krebs, and I know that you'll want to hear that.
Is there an amendment? There is an amendment on this bill?
This is in somewhere. She read it to us.
Okay, I'm sorry. All right, that's my only concern. If that's in there, I didn't see it.
It is. I heard it.
Trust you.
Can you find that, Aaron?
There are no amendments on the bill. No.
Can you find the wording that talks about that they have to be basing the length of stay and the discharge on the
It has to be
medical
based
criteria?
on medical necessity, correct?
Right.
That's in the bill.
So they can't just throw a person out to keep their numbers down, Delegate Krebs. I appreciate that you're.
But no, that wasn't their point was if we have this average length of stay, it could take away their flexibility through federal funding on the additional days with certain persons. It had to do with the federal funding. I'm just saying that.
But I think if I may, Chairman, that Delegate Krebs, we can make this amendment that we're discussing in the reporting, we can report on that as well. So we know what the impact is. I think it's a fair question. Okay, my pleasure.
Okay. So Aaron, can you do a conceptual amendment? Do we need to hold this bill to get that? Let me ask Delegate Krebs and Delegate Shalega, who were the most concerned about this, that brought it to our attention. Do you trust a conceptual amendment, or do you want to wait and hold this bill?
I think, well, Delegate Hill has her hand up. I don't know if she's weighing in on this, but I trust Aaron to draw something. I think we're in agreement here that none of us want to, pass a bill that jeopardizes a significant amount of federal funding, and the sponsor of the bill is shaking her head yes. So, sure, I'd be, happy to, if Aaron's comfortable with that, doing that.
And I just don't want to inadvertently hurt people that need it, but I'm comfortable with it as well. If you just, look at the testimony of the department, the last paragraph.
Yeah, Aaron, you need time, or could you do it conceptually later?
So I would do an annual report from MDH on the average length of stay, post implementation of the bill, and then potential impacts on federal funding.
And potential impacts on patients that might not have their stay lengthened.
So potential impacts on federal funding and also on the patients who stays were or were not limited based on this. Something like that.
Yep.
Okay. Okay, I wanted to finish that because I didn't assume Delegate Hill's question was going to be on this exact subject, but I could be wrong. Delegate Hill.
Yeah, it's on the exact subject.
Oh, sorry.
It's okay. It's not a problem. And it's just following up on the sponsor, Delegate Bagnall's point. So when we're looking at the cost, and I think, yes, we don't want to sacrifice federal money, but I think it's important for us also in the report to see, what is the impact of this legislation on those stays in the emergency room where people are being held for multiple days, waiting for 5 denials, and what those costs are to the state for those people to be held in the ER, and that they also, when they're looking at the effect on patients, we should also be seeing the ones who are admitted under this bill and transferred to other smaller facilities. So our waiver that started in January, according to the fiscal note, allows patients to be admitted to these larger facilities, these larger IMDs. If they're pushing up against that length of stay, one of the options the IMDs have is to then transfer them to a smaller facility that Medicaid would cover. So we should also be looking at that, is what I'm suggesting. Just a thought.
I don't have any comment. Does Delegate Penny-Melnick or Aaron have anything to say?
Just as the report gets more complicated, I'd feel more comfortable working with the department on what's actually doable
Okay,
and attainable, what kind of data.
okay, hang on. Delegate Bagnell.
Thank you, Madam Chair. And I just wanted to remind the committee that this is codifying the current policy of the health department. So we're not actually changing their current policy. We're actually preventing future decisions that are not medically based, which was the policy that they have suspended since we've gotten the waiver.
Okay, we're going to hold this bill. We're going to ask Erin to craft an amendment. We're not going to do a virtual amendment today or a theoretical amendment. We're going to actually have the words, and we'll take this up at our next voting session. I'm not sure when that will be. Okay, we want to get this right. This is.
Madam Chair, I mean, if it's my contribution that's causing us to hold the bill, and Delegate Bagnell points out they're already doing this, then if all we want to know is, are we losing federal? My concern is just that we always talk about money we lose without talking about what we've gained. And so if we're just looking at the loss without comparing it to what we've been paying before this waiver and before this bill in emergency room stays and all of that, that's a problem. But if that's not, we don't necessarily have to include that.
Delegate Hill, I think it's worth including. I think it's worth knowing how many emergency room days we're avoiding, if possible, by doing this way. I think it adds value to an already valuable discussion that we've had. So I think it's worth holding this bill, and I would like to do that. Delegate Benderi.
Thank you, Madam Chair. I believe their amendment won't affect that. I think the intention of the bill is already there is a disparities between the Medicaid and commercially insured population, as these barriers are not in place for commercially insured patients, right? I mean, I hope the amendment does not affect that. And I would love to know if there is just the assumption that we are going to lose the federal dollars, or there is something in statute. I would love to know that, or just that is the assumption.
I think, if I may, Madam Chair, that putting in, I feel comfortable holding it because we should have a balance report. It should not be just on the money. I mean, I know we make decisions. I remember, it reminds me of Delegate Hubbard, who used to say the money should follow the policy, not the policy should follow the money. And in this instance, so many of us have seen, I know I have, our constituents in the waiting room forever, right? And I think that we allow it for the commercials. We should allow it for Medicaid as well. So taking Delegate Hill's language is important because we should also have the benefits, which a lot of these fiscal notes never account for that. Mm-hmm. It's always the money, but I think it's important. So I am supportive of the chairman's decision to hold it and to give Erin time to comfortably draft it with the department. So those are my thoughts, Chairman.
Thank you. I appreciate that. So I'm going to hold this bill till our next voting session, unless there's a voting session tomorrow, in which case I'll hold it somewhat longer. But I don't know anything about that yet. So we'll get this right. Okay. So Delegate Bagnell's Bill 684 is held. House Bill 820.
You need to go back to the doula bill.
Oh, I did it again. Do you think I'm not liking that bill? It's not true.
No, it's gonna just breeze through. I have to get an easy bill. Let's do it.
House Bill 669, and that's Erin and Delegate Pena-Milnick.
House Bill 669 requires the Maryland Department of Health to ensure that doulas providing care under Medicaid are participating doulas, review participation in Medicaid of participating doulas and program recipients, and evaluate the effectiveness of doula services covered by Medicaid. The bill establishes requirements for participating doulas and specifications for covered doula services. There is a reprint of the bill on pages 42 to 46 of your packet. This reflects amendments adopted in the Public Health and Minority Health Disparities Subcommittee that clarify that doulas provide non-clinical services, that doulas supplement the services of healthcare providers and provide prenatal coaching instead of prenatal counseling, replaces the term medically necessary with medically indicated, and provides that the bill does not limit the authority of the HSCRC to set hospital rates, and strikes the requirement that MCOs provide home visiting services.
Delegate Penny Milnick, your
So
easy
we
bill.
discussed this bill, and basically, as the fiscal note says on page 2, Maryland Department of Health is set to begin Medicaid coverage of doula services once regulations are promulgated, which is anticipated to occur February of 2022. The bill generally codifies key components of MDH plan of implementation for doula services. Therefore, it's cost neutral, it says. And we discussed this bill. We took some amendments to make some people happy, bring them to the table. And we discussed it in subcommittee, and the vote was unanimous. I move the amendments.
Thank you. Is there a second?
Second.
Is there any discussion of the amendments? All those in favor say aye. All those opposed, no. Please raise your hands. I see no hands in the panel. The amendment passes unanimously.
I move the bill as amended.
Second.
Discussion? All those in favor say aye. All those opposed, no. Please raise your hand.
You have Delegate Kipke and Delegate Shalega. They have
Are
questions.
you voting or are you questioning? I'm sorry. Did I miss?
I have a question.
I'm going to start with Delegate Shalega, whose hand apparently got up first. Delegate Shalega.
Sorry, yes, I was unmuting myself. Just for the record, because we do have people watching us and this is a public record. There were concerns about the conscience clause, and Aaron pointed us to Health 20-214 that says a person may not be required to perform an abortion or assist an abortion. So I just want to make sure that for the record, we made that clear. Otherwise I would have had an amendment. Thank you.
Thank you.
Thank you, Delegate Shalega. Now the only hand I see, there's Delegate Kipke, your hand went down. I'm going to leave him in that place and you'll be next, Delegate Lewis Young.
Just a quick question. The under Medicaid, would whatever it is that abortion doulas do, now that I've learned that they exist, those services that they provide, is that reimbursable under Medicaid?
This bill doesn't deal with abortion at all.
I agree with you, but we under the framework of this bill, doulas will be able to be reimbursed for the very good work that they do. I've witnessed it personally, but you can Google and you can learn that they do some type of assistance with not providing abortion, but providing certain types of services that isn't abortion, but it's related to someone getting an abortion and the aftercare of abortion. So I don't know if it's a question for staff, but is that reimbursable with the passage of this bill?
This bill is very specific and defines a birthing parent as an individual giving birth and who is receiving doula services throughout the parent's pregnancy, including prenatal, labor, and postpartum period. So it's very specific to serving
birth.
To a birthing parent.
That's great. Thank you very much. All my questions have been answered.
Thank you. Delegate
Thank you for the
Bandera.
question.
Delegate Banderi.
Thank you, Madam Chair. I believe my question is answered, but wanted to just reiterate that this bill just codified the COMAR expanding Maryland Medicaid to cover doula services for pregnant and postpartum low-income Marylanders, right? I hope nothing to do with abortion. I believe Erin clarified that for the record.
Okay, we got the yes on that. Erin, Does this bill still have, or let me try again. Delegate Penny Melnick, does this bill still have postpartum in it, or is it just up to birth? I cannot recall how it was left.
We did strike postpartum from the reimbursable
Yeah.
services.
Okay. I picture doulas like my daughter had one, and it was through the birth and there wasn't anything after, so I was surprised.
No, page
It
3
does
of,
say, it says on page 5 of the reprint, which is handwritten 46, a managed care organization that participates in the program provide medically indicated doula services to pregnant and postpartum enrollees. I think postpartum is important with, maternal morbidity issues. I'm glad to see postpartum's in there.
but postpartum periods on line 10 of the bill, page 3, has been stricken.
It's still at the end then.
Yeah, because page 3 of the bill, it says it's removed. Postpartum period means the period within 180 days after the conclusion of labor and delivery.
That's just the definition. So
Yeah.
the definition was stricken, but the MCOs, which was what
That's in the bill on page
Lega
5.
was reading from, yes. The MCOs would still have to provide the medically indicated doula services to pregnant and postpartum enrollees.
Okay.
And we know that the postpartum is so important, right? Because we have a high maternal mortality rate in the state of Maryland. So that is really important. And I know starting in April, I believe we're going to cover up to a year. This is.
I'm sorry, I thought it was
really-
unclear in my answer before. It was the definition of postpartum period that was stricken from the bill.
Yeah. Thank you.
Okay. I see no other hands. Remind me, since I don't have a note, this does have an amendment?
I move the amendment.
Yes.
And we voted on the amendment.
So I move the bill as amended, Chairman.
Second.
Is there any further discussion of the bill as amended? All those in favor say aye. All those opposed, please raise your hand. I see no hands in the panel. The bill passes unanimously. Now, are we time for House Bill 820? I missed anything else?
No.
Okay, let's go. Lisa and Delegate Cullison.
You have a question by Delegate Bagnall, I think. Her hand is up.
Delegate Bagnall.
Thank you, Madam Chair. I was just wondering about a potential sponsor amendment for the doula bill.
There is an amendment on the bill. So if people want to sponsor that bill, we can be co-sponsors because it won't slow it down. Is there anyone who doesn't want to be a co-sponsor of that bill? Would you raise your hand? So take yours down, Delegate Bagnall, please. Great. Okay, so I see 4 hands of people who do not want to co-sponsor this bill, and that would be Morgan, Chisholm, Shalega, Riley, and there's a 5th one. There's Delegate Saab. I see you. Okay. Have we got that, staff? Somebody dropped off because I only see 4 now, but I'm assuming there's still 5.
I have 5.
Good. That's
Yes, Saab, Riley, Shalega, no, or no's. Correct? Okay. And then the rest of the committee. Okay.
Not those. Just
You are not going to be a co-sponsor.
correct.
Okay. House Bill 820.
Okay.
Did Delegate Hill have a question on the last one too?
No, it could wait. I didn't know if we were going to wait till the end to look at other bills we might want to be co-sponsors on, but I can wait since we've moved on. Thank you.
Yeah, we didn't address it. Make sure that there's an amendment on the bill for us to consider it, okay? We'll do it at the end. All right, so here we go. Lisa.
820.
Right, Lisa.
So House Bill 820, for purposes of requiring coverage by Medicaid and health insurance carriers, the bill repeals the requirement that rituximab be approved by the U.S. Food and Drug Administration for the treatment of pandas and pans.
Okay, so a couple of years ago, when we passed a bill that addressed this very difficult and tragic infection that generally prepubescent children get sometimes as a result of strep, the medications that doctors have found that work are those that are not necessarily designed and labeled for pandas. In 2020, we felt comfortable with IVIG. Now rituximab is being used with children in very severe conditions and monitored completely by physicians. So we're asking to with this bill, we're asking for the physicians to have this tool in their toolbox as well. And it was unanimous on the subcommittee.
No
Unanimous
amendment?
support. No amendments.
Would you like to move the bill?
I would like to move the bill, yes.
Is there any discussion on this bill? Seeing none. Oh, there you go, Delegate Shalega.
If I could have done the hand raise that goes like that, I would have done it. So good job in helping these.
There is one of those.
Oh, you're right. I should find it. Okay.
There is. I'm not sure I could find it, but I know it's there because I hit it by accident once. We have a lot of small people with us today, which is very lovely. It's nice.
That's very good.
Both of them. Very nice. Welcome to the party, kids.
My clap doesn't look like a clap. It looks like a hand. So
yeah.
Okay. It was moved and seconded. No discussion. All those in favor, please say aye. All those opposed, please raise your hand. I see no hands. The bill passes unanimously. There was no amendment, so we cannot all be sponsors. I'm sorry about that, because I was thinking about how far we've come on this issue in, I don't know, about 4 years. Is that about right, Delegate Cullison? Okay, good work. House Bill 937. Aaron.
House Bill 937 establishes the Abortion Care Clinical Training Program and MDH and the Abortion Care Clinical Training Program Fund to support the program. For each fiscal year, the governor must include in the annual budget bill an appropriation of $3.5 million to the program. The bill specifies that a qualified provider, in addition to a physician, may perform an abortion. There is a reprint of the bill on pages 47 to 58 of your packet. This reprint merges House Bill 937 with House Bill 952. So it reflects the versions of the two bills that you received in last Friday's voting session. They've just been merged onto one bill. If you look on handwritten page 51, there is an amendment to House Bill 937 that requires the coordinating organization to have training standards that focus on the provision of culturally congruent care and include implicit bias training. On handwritten page 53, beginning on line 25 and on to line 3 of page 51, this amendment would maintain the current law regarding parental notice requirements. And then starting on handwritten page 55, after line 21, this is where the provisions of House Bill 952 are added to the bill. House Bill 952 establishes requirements regarding how an insurer, nonprofit health service plan, and health maintenance organization, as well as Medicaid, must cover abortion care services. The Medicaid language is on the bottom of handwritten page 55. And on page 56, that includes the requirement that certain private health insurers cover abortion care services. In the middle of handwritten 57 is the requirement that by January 1st, 2023, the Maryland Health Benefit Exchange must adopt regulations to provide a subsidy to cover 100% of the cost of premiums for individuals in the state-based Young Adult Health Insurance Subsidies Pilot Program for calendar 2023 and track the impact of the subsidies. On the bottom of handwritten page 57, the Maryland Health Benefit Exchange must convene a work group on consumer information about abortion care coverage, conduct a study on extending lost dollar coverage, and submit specified reports. On the bottom of handwritten page 57, the Maryland Insurance Administration must collect specified data from state regulated plans and submit a series of reports to specified committees of the General Assembly.
As you know, this bill did not go to subcommittee because I believe that this is a bill that should be considered by the committee as a whole, not one subcommittee. So there is not a subcommittee chair that will be answering questions. I think for the most part, we're going to let the sponsor answer the questions, but there may be areas like insurance where Delegate Cullison may want to step in, or some things where some other person may, and that's fine. So with that, I will begin with questions. Delegate Morgan, your hand is raised first.
Thank you, Madam Chair.
Mhm.
Quick question. So we just combined two bills into one. There wasn't a cross file. There was a cross file one bill over in the Senate. Is there a bill over in the Senate that does the same thing as putting those two bills together?
Yeah, the way this bill has been amended reflects the cross file in the Senate.
Well, what's the cross file number in the Senate?
890, Senate Bill 890. And I apologize. I think I mentioned before the hearings, I should have put it in as one bill, and this whole thing is my fault, so I apologize. But if you look at the fiscal note for Senate Bill 890, it will reflect, with the exception of the sponsor amendments that we put on the identical bill.
Okay, I'll take a look at that real quick. Thank you.
Delegate Kelly is taking a hit that she doesn't deserve to take. So it's nice of you to do one, but she's really not culpable for this. And that's all I'm going to say about that, even though she is very gracious.
Well, I did want to say, I know we have a lot of questions, but just, really thank the committee. Everybody has been very good at dealing with these difficult issues. And I'm very thankful for, we are a family and everybody doesn't always agree on issues in a family. I know in my family that's the case, but, I think that I wanted to mention that the amendments that went on the bill, outside of merging them into one bill, the other amendments came from conversations, came from things we heard in the hearing. We wanted to address what concerns we thought we could that were raised. I know Delegate Morgan and Delegate Kipke had some questions that we tried to address with the amendments. So I just wanted to note that.
Okay, Delegate Morgan, have you got enough answer to your question?
Yeah, I'm pulling up fiscal note now. Since you mentioned our names and what questions I had, you want to go over those amendments, especially for like a religious exemption?
Yeah, absolutely. So we found when we took a close look at the bill, the intention was always to maintain the religious exemption. But we did find that in the insurance section, we had inadvertently, while making sure that the existing exemption applied, so that a plan that already had an exemption for contraception would have an exemption for abortion care as well. It occurred to us that there may be some plans that wanted to cover contraception, but did not want to cover abortion care. So we wanted to create an exemption just for that, in cases where a plan would need an exemption, that it wouldn't have to be an exemption for both. So we added that in. So in addition to the exemptions that Delegate Shalega mentioned earlier on the doulas bill that covers providers and institutions, we also have that insurance exemption in the bill. And so that is in amendment number, hold on, I'm looking, number 3 on page 56 of your.
Yeah, if you look on handwritten page 56, it's right in the middle of the page, paragraph 3.
So in the bill, it also talks about $3.5 million worth of training. Do you have any idea of how many people that would train?
In terms of how many providers that's going to train? I think the program is going to be, I know the program is going to be set up by MDH. So it is, just an outline right now, but I think the goal is to both train practitioners in multiple sites so that they can work across the state. So, we're gonna know more, I think, as the program is set up, what those goals are and after MDH has established the guidelines for the program.
Okay, thank you. Thank you, Madam Chair.
Yeah.
Thank you, Delegate Morgan. We're now going to go to Delegate Lewis Young.
Thank you, Madam Chair. Did the insurers raise any implementation concerns or any other questions?
Actually, thank you for the question. If you notice, the carriers are silent on this bill. They have gone over the bill. They have looked at it. We worked through any concerns that they had prior to dropping the bill. So we're confident it is implementable. Thank you for the question.
Thank you. And I also have a question on 952. Are we going to take that separately, or now that the bills are being combined, are we taking those?
Yeah, so
together?
we're discussing that now. Yes.
Okay. Does this just protect abortion? Nothing.
Oh, your question is on 1171. That's the speaker's bill. That one we will be discussing separately.
Okay. All right.
Yeah.
Thanks. I thought that was part of.
I know, too many numbers. It is very unfortunate.
Thank you.
Thank you. Delegate Saab, you're next.
Thank you, Madam Chairman. Just trying to get some clarity on a couple things. So the day that I know there was some concerns that were brought up on the day of the hearing that the bills 937 and the two bills, Ariana's bills, I'm sorry, I can't think of the other number.
That's fine.
Were basically paired together, and now they're being merged into, or I guess it's getting amended. So now sorry, 1 second. I need the numbers.
It's 952 and 937.
So 937 is now the bill, and that 952 has been amended onto or merged. So now it's a new bill. Are you withdrawing the other bill? Is this going to get withdrawn?
Process-wise, what happens? I imagine eventually it does, I suspect, but I guess that's a question for council. Is that the process we would follow?
It would be up to you. Like, you could take no action on 952. Nothing happens till you make that decision to withdraw the bill.
I'm not planning to put it on a voting list, Delegate Saab. She can withdraw it, but I'm not planning to put it on a voting list regardless.
But it is on the voting list today.
Yes, but I'm not, I will go right past that and assume that we've done it in this bill. And I'm sorry to have not thought to say that at the get-go. I should have, and I didn't. We're going to use this vehicle to discuss both bills.
So from a procedural aspect, does this mean that, so do we have to have another hearing on the bill since it's a different bill, or are you treating it as the other bill as an amendment on the one bill?
It's an amendment, and the double bill is exactly the same as the two bills separately. It's 2 + 2 = 4 plus a few small amendments that you've heard about.
Right. So from a procedural angle, since it's a different bill, does it need to have another hearing on the new bill as amended?
No, because it's not a new bill. It's just a bill as amended. We don't have separate hearings on amended bills. We just deal with the amendments and pass them. We've done this many times where we've merged multiple bills into one bill. This is not in no way precedent setting.
Okay. All right. Thank you, Madam Chairman.
Thank you for the question, Delegate Saab. Delegate Cullison.
Thank you, Madam Chair. Delegate Kelly, you worked with the insurance carriers and you learned that most of the commercial carriers were covering these abortion care services. But they had deductibles or co-pays or co-insurances, but this bill removes those. Why is that important?
Thank you for that question. As we know from all different types of healthcare, the deductible and the coinsurance can be a huge barrier, and particularly with abortion care when it is time sensitive, delays that can be caused by deductibles can be really critical for care. So in order to access care in a timely manner, removing the deductible will really make patients' lives significantly improved. When we're looking at what is going to be potentially a real crisis in terms of access to care. When we look at what has happened in the other states that are adjacent to Texas, we see that the wait times have increased from 19 to 22 days in those neighboring states. I'm thinking about that when I'm thinking about how critical it is that people access care in a timely manner in Maryland. So removing the deductible will enable people to not have a financial barrier in terms of their access to care, which will help us with the appointment wait time issue that we are going to be facing potentially very soon.
And the carriers have said that's doable.
Yes, they have. And this is, as you remember, we did something very similar with the Contraceptive Equity Act 7 years ago.
Right. Okay. Thank you.
Thank you.
Okay, Delegate Krebs.
Thank you, Madam Chair. I was looking at the bill and it looks like I was looking at an abortion under section 2208. The original language is an abortion must be performed by a licensed physician. Oh, Delegate Penny-Melnick, your office is calling me about our meeting that's going on. I don't know if you want to call them back. You want to respond? Tell them to postpone it. Sorry.
Yeah, I'm not in the with them, but they're doing the meeting anyway. They're holding it. Don't worry about it.
Now. Okay, so anyway, I'm sorry about that. So section 2208 says an abortion must be performed by a licensed physician. That's the existing language in law. And it's been switched to qualified provider. And I see the qualified provider is defined. But my question is, for surgical abortions, are we allowing non-physicians to be able to do surgical abortions in this bill?
Yes, thank you for your question, Delegate Krebs. So as you may remember from the hearing, right now we already have a letter from Attorney General Frosch clarifying that advanced practice clinicians can provide medication abortion. This legislation is going to codify that and allow that to continue while also enabling them to do procedural abortion. And there was testimony, if you remember in the hearing, from an advanced practice clinician practicing on the Eastern Shore about how sometimes that is very necessary. She had a patient with low hemoglobin levels, and it was a tremendous barrier. She wasn't medically eligible for the medication abortion, and she had to come back over several weeks to multiple appointments, missing work many times because she was not able to get to Baltimore for a procedural abortion. And that is something that ACOG, our obstetricians and gynecologists in Maryland, support and deem absolutely safe. I think it's really important to note that the provider community is unified, that this is safe and appropriate for advanced practice clinicians to be doing.
Well, I just think it's interesting. Usually MedCai comes in all the time on anything with scope of practice, and all of a sudden on abortion, it's like wide open. So it's disturbing. We also have testimony in the file. They say it's perfectly safe, but we do have testimony in the file about women and girls who've actually died during the abortion process because of folks that were not necessarily trained. So I'm concerned about we are changing the language from the licensed physician to this qualified provider for surgical abortions. That's to me, it's unprecedented, especially all the scope of practice bills we have or other things. So I object to that part of this bill, but thank you. So for all intents and purposes, these other providers can do all from prescription-based all the way through surgical for all of these providers. Is that correct?
They do have to be competent to provide the care, of course, but under those circumstances, and I would refer you to the ACOG letter. It does say abortion is one of the safest medical procedures performed in the United States, safer than other routine medical procedures. And the biggest threat to quality of abortion care in the US are unnecessary and burdensome government regulations. So the purpose of this bill is to remove an unnecessary and politically motivated barrier. These same providers are already doing miscarriage management, which is nearly an identical care procedure. They can't do abortion care for a political reason, not for a public health related reason. So that's why it's important to remove that barrier.
Well, it's interesting how they say how safe and all it is, but 90% of providers do not perform it. So they all think it's so safe. I wonder why the 90% don't do it. But so you just said they have to be competent. Who determines the competency?
It's the same way that we do all healthcare, right? The goal with this bill, and I understand that for many of us this is a very emotional issue, but But the goal is to treat abortion care the same way we treat all other forms of health care, right? So the way that you are more familiar than anyone else on this committee probably with how our licensure works and how the discipline process works and how peer review works. You understand that if someone is doing heart surgery or if someone is treating diabetes, it's the same. And we want abortion care to be treated exactly the same as any other health care.
And I just have one further question. So the folks that don't, and I think you already said, that folks that do not want to participate in this, they don't have to participate. The providers, is that accurate?
Absolutely.
Qualified providers?
Absolutely. Nobody would be required to provide this care if they did not want to.
Thank you.
Delegate Shalega, you're next, followed by Delegate Kaiser.
Thank you, Madam Chair. I do have a few questions as well. The 0% copays, I made a note here. Hold on. I have a few notes. So you talked about the parity for, was that for vasectomies?
We do have no cost sharing for vasectomies, and the same exemption that we've created eventually for the high deductible plans is in this law as well. We learned from that.
Also, did we do vasectomies and tubal ligations with 0 copays?
We did.
And then why aren't we doing that for pregnancy if we're going to do it for abortion?
You know, I have thought of that, Delegate Shalega, and I will happily be the first co-sponsor if you want to put that bill in. Sign me up.
I think here's your chance to just put it in the bill. If you want to, you know, if you're going to make insurance companies pay for an abortion for 0 copays. My next question is, hold on. I made notes in the bill because, you know, obviously I read it. The medical provider that Delegate Krebs was talking about, I think it's on page 5 of 8 in this section. Qualified provider means a physician, nurse, nurse practitioner, nurse with midwife, licensed certified midwife, physician assistant, quote, or any other individual. Would you, that seems a little bit broad, or any other individual. Can you tell us why you left that so wide open?
Thank you. Yes, Delegate Shalega, if you remember from that list you just read, we just said licensed certified midwives who are qualified to provide this care. They're also a new profession we just created, I believe last year in Maryland. The point is to ensure that we don't have to keep coming back year after year and adding to the laundry list. What we want is to make sure that it's only people for whom it is in their scope of practice. They are competent to provide the care. At this point in time, it is those providers you listed, licensed nurse practitioners, nurse midwives, physician assistants, and the licensed clinical certified midwife, licensed clinical midwife, sorry, brand new profession that Delegate Bagnall just passed a bill for the other year. What I was worried about and why I put the language in that way, even though we know exactly what we're saying, is that, you know, it has been 30 years since we have had a bill related to abortion care on the House floor in Maryland. And it will be another 30 years, I would suspect, before we have another one. So I wouldn't want us to be falling behind the way that we have, you know, the physician only restriction is a perfect example. That's been on the books for 30 years. It's been not clinically appropriate for half that time probably, but we have not been able to update it. So the language is written that way just to ensure that we can keep up as time changes over the decades.
Okay. And who's going to decide who any other individual is?
That any other individual language is, it wouldn't automatically happen. We would have to license a new profession. We would have to establish it. So there would always be other legislative action required, just not in this particular section of statute.
Okay.
So the legislature would make that choice.
Okay.
Can I chime in real quick?
Yes.
It's any other individual. So you're on the top of handwritten 53.
On 6 of 8, let me look and see. I printed the bill that you sent separately, but it's
on 6 of 8. So it's any other individual, and then it's who is licensed, certified, or otherwise authorized by law to practice in the state, and for whom the performance of an abortion is within the scope of the individual's license or certification.
Okay, so so it would be like MedCai or the licensing that would determine that. Okay, because I would,
It's not just anyone.
Okay, and thank you, Aaron. For the record, would just want to mirror Delegate Krebs's thoughts, and, late-term abortions certainly are not safe, and we wouldn't, I'm sure you don't want just anybody doing a late-term abortion. That's very dangerous for the woman, and obviously for those of us fully for the baby as well. The final question I have would be on it starts on page 7 of 8. The department shall adopt regulations that are both necessary and least intrusive method to protect the life or health of the woman. Is this the health of the woman carve out that I talk about every year on the House floor, where the health of the woman can be I'm sorry, I'm trying to use the right language here. So a physician, a woman could tell the physician, my mental health is at risk, and consequently the abortion doctor could then perform an abortion on a woman who's over 24 weeks.
I think you are talking about the part of the statute that is already the existing law. Is that what you're talking about, or you're talking about the bill?
Yeah, in the bill, it says health of the woman. And so I'm assuming
I'm sorry, because you said page 7. What page of the?
It starts at the bottom 7 of 8, and then the word health is on 8 of 8. And so, there are some, the language above it talks about the viability of the baby, and that before the fetus is viable, abortion is, completely unfettered. And then afterwards, it's, the life, obviously we have things we do agree on, rape, incest, life, health of the mother kind of thing. But this health of the woman aspect, I'm assuming that's where you're maintaining that caveat where mental health is part of that, which then, makes late-term abortion available and legal.
So yeah, I think what you're referring to is the existing law. There's nothing in this legislation that in any way changes the existing law in Maryland. So that I think is what you're talking about, the existing law. The bill doesn't affect that.
So that's still, that's something that obviously we disagree on, but is going to be maintained in the law in Maryland. Okay, those are all of my questions for now. Thank you.
Delegate Kelly, do we have a specialty that's called abortion doctor? To my memory, we have no such thing in our code or in any kind of practice. That what we have are doctors that may specialize in things like OBGYN, but we don't have a specialty called abortion doctor, do we?
No, we do not.
Thank you. Delegate Kaiser.
Thank you, Madam Chair, and thank you, Delegate Kelly. It's here, not just tonight, but during the hearing, I've heard several things about abortions increasing the risk of death. I've heard in the past that it increases breast cancer. I've heard in the past that it harms future pregnancies. My understanding is that none of that is true. And I think you said it's the political barriers that cause the greatest health risks. Given that, I just wanted to ask, and this is not a long question, but can you tell me the position of the major health organizations, our Department of Health, as well as, I guess, everyone else medical, our health occupation boards, our School of Nursing, our School of Medicine? Have any or all of those groups taken a position on this legislation?
Thank you very much for that question, Delegate Kaiser. As I mentioned before, Maryland's obstetricians and gynecologists are in strong support of this bill, as are the family medicine physicians. There is a huge, the nurses, there's a huge list of healthcare providers who are in strong support of this. There is no health organization from the boards or the Department of Health or even the insurance carriers that have opposed this bill at all. The only opposition we have to this bill is from the folks who are opposed to abortion.
Thank you.
Delegate Chisholm, looks like you're next.
Thank you, Madam Chair. And with all due respect for a couple of the last comments, when we talk about it being safe, well, of course, it could be safer in the procedure for the mother, but we talk about this as if there's only one person involved. We're stomping out the life of an unborn child. We have to reflect on that. And I know that some of you don't always, but to me, life is precious. Every single life. And we have to remember that when we talk about these things. And I know it was said that, you know, we want abortion healthcare to be the same as healthcare. Well, our healthcare system is designed to protect life, to do everything possible to protect life. So that's just a point. My question really is about the $3.5 million to train. Was there any consideration given? I know we hear a multitude of bills every year about, you know, infant deaths and post-mortem deaths, and did we give any consideration into maybe that money would be better used to save the babies that are born and to save the mothers that have given birth?
So thank you for your, sorry, a little feedback, a lot of feedback. Thank you so much for your question, Delegate Chisholm. And, you know, I appreciate that we can agree to disagree on this issue in a collegial way. You know, I really think about this issue as something that has to do with making sure people have their own individual rights. And I think one of the most important life decisions that any of us will ever make is whether to become a parent. And I also think that when people have access to the full range of healthcare services, including birth control, abortion, and maternity care, to Delegate Schlegel's point, they're healthier and their families thrive. So I think one of the most important things that we can do for the children that are here today and the families that are here today is make sure that everybody has access to abortion care as part of their health care. In terms of the $3.5 million, and again, I have been in this legislature for 12 years and I have supported spending on children as much as possible because I love children. I have supported increasing subsidized childcare. I have fought tirelessly for paid maternity leave and paternity leave for families. You know, I believe that we should be putting our money where our mouth is, and that supporting kids is one of the most important things we can do. I also think that this $3.5 million is really important because we have a provider shortage already, and we are going to be facing a really increased challenges in terms of providers who want to provide this care being able to access the training that they need to provide this care. After the Dobbs case, if 26 states do ban or severely restrict abortion, that's 26 states where they're not going to be able to have training in providing abortion care. We already know that many people don't have access to abortion training right now today, and it's going to get worse. So while I truly respect your passion for children, and I share it, I do agree. I do believe that this money is well spent and is going to help people.
Thank you. And if I could have a follow-up on that, as far as the training goes, and this was interesting to me in the bill, and I'm asking this question with all sincerity of what the impetus of it was in, and I'm taking this from the Senate bill because it's easier for me to read. Part of the training is to increase the racial and ethnic diversity among healthcare professionals with abortion care training. I guess what problem is that solving? I mean, what are you aiming to try to do with putting that into the bill?
We have had many pieces of legislation. Just this year, we heard a bill yesterday. We passed a bill earlier this session from Delegate Ampry. We heard a bill from Delegate Smith, Delegate Penny-Mellon, Delegate Wilkins have worked on these bills. We know it's incredibly important for people to have providers in their community who know and understand their community and represent their community, providing care for them. And as I keep saying, abortion care is health care, and for communities that are underrepresented in the healthcare provider field, it's really important that we work on addressing that issue. So that is the meaning of that, and that is also the purpose behind the amendment to address to ensure that training fund focuses on the provision of culturally congruent care and does include implicit bias training.
I guess my point is the people that really want to get into this and have a passion for it will gravitate towards it. We don't need to be encouraging people to get into the abortion businesses.
It's about making sure that opportunities are available for people who are looking for opportunities, making sure that they have access to those opportunities for training.
Thank you, Delegate.
Delegate Bagnall, followed by Delegate Pena-Melnick.
Thank you, Madam Chair. And I just want to thank this committee for being so respectful of each other. I know this is an emotional topic, and I don't think it's a mystery that I spend a lot of time in this committee working to destigmatize healthcare, usually in the mental health and behavioral health arena. And I appreciate that we are being so thoughtful with our language, because I will tell you that this is very emotional for me, because I have had 2 spontaneous abortions, which is the clinical term for a miscarriage. And I was able to define that experience, and I was able to have the full scope of healthcare. And that really is what we're talking about here, is ensuring that regardless of where you are on that journey, that we have access to that full spectrum of healthcare without feeling stigmatized. And so I really appreciate this committee. And so I wanted to ask a clinical question along those lines, which is regarding the insurers. Was there any concern that they would not be able, that the insurance plans would be able to implement the requirements as defined in this bill?
Thank you for your question. No, there was no concern expressed at all. We worked closely to make sure that this would all be implementable in the timelines that are in the bill. So they were confident that it was doable.
Thank you very much.
Thank you very much.
Delegate Pena-Melnick, followed by Delegate Hill.
Thank you, Chairman, and thank you, Delegate Kelly. So my question is, when we talk about access and insurance, will a church or religious affiliated institution be required to purchase abortion coverage?
No, absolutely not. And on the insurance side, we made sure that there's an additional amendment on the bill today to ensure that the religious institution can get an exemption for either just the abortion coverage, or if they already have a contraception exemption, also get an additional exemption.
Thank you, Chairman. I appreciate it.
Delegate Hill, followed by Delegate Lewis.
Thank you for this bill, Delegate Kelly. So I just want to ask, my understanding is that we can look at history 50 years ago, and we can look at what seems to be coming. And there's nothing to tell us that making it harder for people to have abortions will stop people from having abortions, correct? So the assumption is that just as they have for thousands of years, people will be seeking healthcare through abortions for whatever reasons. And that if we're concerned about their health, and frankly, the health of the fetus, to the extent that we don't want people undergoing procedures, and as the Delegate Chisholm said, taking the life of the fetus, we don't want that to be drawn out. We don't want those botched abortions where fetuses are half born, or other things, that we would want people performing them to be trained and responsible so that as we go back 50 or 60 years, we're not going back to the days when folks are going in the back rooms or in the alleys or in hotels to have medical procedures. Is that what part of this is about?
Thank you for your question, Delegate Hill. And, as I have been thinking about this bill, you are an outlier in that you are a physician, but in general, legislators are not physicians. And, that is why it's so important that we don't have political barriers in the way of people accessing their health care, right? We want people to be having these important health conversations with their clinicians, with the people who they love as they're making this difficult decision. And it's a decision that people have to make for themselves, right? They have control over their own bodies. It's not the business of the legislature to be in that decision for them. What we want to do is ensure people have access to healthcare as they go through their process of making their decisions.
Delegate Lewis, followed by Delegate Morgan.
Thank you, Madam Chair, and thank you, Delegate Kelly, for this bill. I also really appreciate the collegial, professional, and respectful conversation and debate that we're having. The subject of reproductive rights is also really important to me. Having spent more than 20 years of my professional career working around the world in 14 countries on 3 continents, in the field of reproductive health and infectious disease prevention. So I did a lot of work with mothers seeking prenatal care, well baby care, as well as women of all ages seeking to have control over their fertility. And I'm about to lose my battery. There we go. But one thing I can say is that, having worked in so many countries and so many parts of the world, I've been in places where reproductive rights, sexual rights, access to family planning, as well as abortion care. I've been in places where those things are circumscribed or outright banned. And I can say that I dread the emergence of similar oppressive denial of healthcare here. So I'm glad we're trying to do something for people to have access to control of their fertility in safe and healthy ways. With that said, with my concern about seeing the United States turn into a place like Malawi, which is a country where I've worked, or South Africa, where women die every day from lack of access to reproductive health care, where they still die of trying to control their fertility. I'm curious about the temperature, the tone in Maryland, and I'm wondering, how many bills have been introduced in the legislature this year that would circumscribe or restrict the right to safe abortion, safe medically, safe abortion, and at the same time, how are the people of Maryland feeling? What are they telling us? What's their temperature on the importance of reproductive rights?
Thank you for your question and for the context behind it. Your experience is really amazing, and I appreciate you sharing it. There are 16 bills introduced this year to limit reproductive rights and abortion access in Maryland. That's an all-time high. I've been here 12 years. We've never had 16 bills in this space before. So that is very concerning for those of us who care about this. And I will say that there's a lot of confusion on the ground. I have heard from many people who don't, because of the information in the national news and the uncertainty around the Supreme Court, think that there are already restrictions on abortion and abortion bans in Maryland and our neighboring states. There's a lot of confusion and there's a lot of concern. I think that passing this legislation is going to be very helpful and much needed to address that and prepare us for the actions that our neighboring states will likely be taking in the coming months.
Thank you, Madam Chair.
Thank you, Delegate Morgan.
Thank you, Madam Chair. As the speaker would say, back on the bill, on the bill. On the bill, you mentioned about the insurance companies supporting this.
The insurance companies are neutral. They have no position. They're not in support. They are they're at no position. Yeah.
Okay, it was the health providers, because I was thinking that insurance companies would probably have a profit motive, because pregnancy, last time I checked in the hospital, is pretty expensive.
I assure you, Delegate Morgan, and I understand where you're coming from. I can do math also, but I assure you that they did not come up with this idea. I came to them. They are neutral. They certainly would not want to be seen in that light. But I did think that it was appropriate to ensure that this coverage exists in the private market. And as Delegate Carlson pointed out, most carriers were already covering this. And our goal was really to get rid of the barrier, which is the deductible and the cost sharing, so that people can get their care in a timely way.
Sure. Thank you.
Delegate Riley.
Thank you, Madam Chair. Yeah, I guess this is a tough subject, and it is very emotional. But I'm having a kind of a hard time to figure out how you can say that taking the life of an unborn is good health care policy by mandating our insurance companies, first of all, to have to pay 100% of this, knowingly that we currently already have abortion laws, on the books, and that, there's a good number of folks already in the Maryland General Assembly that, was opposed to that. And I get what Delegate Kelly said. You said probably the majority of the people that are opposed this particular kind of legislation are those that are pro-life. But there are an awful lot of pro-life people in the state of Maryland. And for taxpayers to pay 100% of something that they are very passionate about, and they feel that this is killing an unborn child, especially with this legislation at, 24 weeks? That's a child that's 6 months. It's breathing. It has legs. It has arms. It has a heart. It has lungs. It's a live individual. So this is very passionate to us. And I just, and for it to be a mandate for so many people that are such opposed to this, why are you doing this now? And I get it. You're afraid, Roe versus Wade in Texas and everything, but we're not there. But to move, you've gone over what we currently have. So how can you explain that, knowingly that there's a lot of the population that don't agree with this, including a lot of your colleagues, but then go from what we have now and expand on that and and forcing your taxpayers and forcing the insurance companies to pay for this? And I know that was rambling. I'm sorry.
Well,
but
I can appreciate your passion on this. And I just want to clarify a couple of points that hopefully will, I will not reduce your passion, but at least it will clarify for you. So Maryland Medicaid already covers abortion care. It has since the 70s. What this bill does is making it permanent so that we're removing the political debate. My belief is that people from low-income families, like I grew up in a low-income family, that their rights shouldn't be up for debate every year. So it's important to me that we continue the Medicaid funding that we have already been doing for decades, and not let it become a political football every year. So we're removing the politics, but we're not increasing the funding for Medicaid. And I would say that while I appreciate your perspective, the people in Maryland, polling has shown us that if you ask them the question, should people have the freedom to plan if and when to have children, it's about 92% of people agree with that. So while there are people who disagree with that, the vast majority of Marylanders believe that this is a fundamental right. And we can have that discussion on the next bill. We're going to have some further discussions on that particular topic, I expect.
Follow up, Madam Chair?
Yeah.
Thank you. I hear what you're saying, but in this situation, it wasn't a medically necessary condition that this person has, an abortion. Okay, if they're in a position where they have to have an abortion, it was a choice that they got to that point. And so now you're saying it's a medical condition, but it really was a choice from the very get-go, was it not?
I think, if what we're talking about is Medicaid funding for abortion, I would note that providing funding for abortion, we're not going to do anything to compel women one way or another, right? We're providing the funding, but not providing the funding is going to force someone potentially to carry a pregnancy to term, which is not their choice. There are two sides to the coin of that story.
Fair enough. Thank you very much. Appreciate your answers.
Delegate Rosenberg, and it looks like the last bite at the apple goes to Delegate Cullison on this bill, but we do have a remaining bill. So don't go have dinner yet. Delegate Rosenberg.
Thank you, Madam Chair. This bill asks us to make a policy and a moral decision about whether a woman should have the ability to make a medical and moral decision in consultation with a physician and the people whom she chooses to consult about whether to bear a child. By broadening access to this procedure, we make it far more likely that it will be performed in a manner befitting our medical system, whereby it poses less of a risk for the woman who has chosen to have this procedure. And I think that's the context in which we should view this bill. Thank you.
Thank you, Delegate Rosenberg. Delegate Cullison, your hand doesn't seem to be up. Are you still planning to ask a question?
No, I don't need to. Thank you.
Okay. I will in a second move on to the next bill, but I will thank every one of you for your kindness in dealing with this issue. It is a personal issue, and this committee never lets me down. You are just always such good people, and I am very grateful. And remember, from now until the end of session, you may see a tear here or there, so just forgive that. With that, we will now move on to, let's see what the number of that bill is. Where did it go? Why don't you just tell me, Delegate Kelly? I'm sure you know it.
Are we going to vote?
Yeah, I was going to say.
Oh, I'm sorry. How dumb of me. Great.
I think we need to move the amendments.
Yes, I think.
I'll move the amendments.
Second. Okay, I heard a second. Is there further discussion on this bill? Yeah, it is one bill now. This is House Bill 937, and we know that it's a big amendment with some small amendments as well. I see no hands. All those in favor, please say aye, and all those opposed, please raise your hand and make sure I say your name before we finish.
Are we on amendments or bill?
Sorry, amendments. Amendments. Okay, I see Delegate Kipke, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Landis, Delegate Krebs, Delegate Shalega, and Delegate Saab. I don't see any other hands. Is that accurate? Okay, so what is the tally on that, Richard? Can you tell me? Or Susanna, whoever wants to do this?
1, 2, 3, 4, 5, 6, 7.
7 opposed, and how many in favor?
No, it's 8.
8 opposed.
8 opposed.
Right.
I miss.
Delegate Landis, maybe?
Yep, got it.
And
Yeah.
how many in favor? Somebody do the math for me.
16.
16 in favor. Thank you very much. I just want that to be on the record so that we are clear what the vote is. I see hands. Are those just no hands or are those to explain a vote hands? Delegate Saab? Okay. All right. With that, we will move on to discussion and the
So
vote.
did we vote the amendments and
Oh.
the bill?
No. Would you like to move the bill?
I would like to move the bill as amended.
Thank you.
Second.
Second.
Is there any further discussion on the bill as amended? Delegate Kipke, I think I see a hand, and Delegate Riley might be next. No, okay.
Thank you, Madam Chairman. I'd just like to say that I just absolutely cannot vote for the bill as it increases taxpayer funding of abortion, provides requirement that private insurers cover the full expense. I'm very uncomfortable with the idea that this is somehow going to improve safety for pregnant women when we're moving away from a longstanding policy that physicians have the exclusive are exclusively permitted to do this in Maryland to other types of providers, and for many other reasons as well. I have to vote against this bill.
Okay, thank you, Delegate Kipke. Okay, I see no other hands, but I don't want to miss anyone. Delegate Landis, I do see another hand. Are you unmuting, Delegate Landis?
I just did. I just want to share with you that this conversation is, and this whole situation is very, very personal for me, which is why I can't vote in support of it. I got pregnant when I was 14 years old, and I could have had an abortion, but I didn't. Today, my daughter is 52 years old, and she's living a beautiful life. Having an abortion never even entered my mind, so I cannot support this at all. For my daughter, and for all the other unborn children, and my faith will not allow me. So I love you all, but I cannot support this. Thank you.
Thank you, Delegate Landis. Okay, is there anyone else who would like to say something? All those in favor of the bill as amended, please say aye.
Aye.
Who are opposed, please raise your hand and make sure I name each of you. And I believe there will likely be 8. Yes. And I believe that's the same 8 that were opposed. Delegate Morgan, Delegate Chalega, Delegate Kipke, Delegate Chisholm, Delegate Riley, Delegate Saab, who's only written here as Sid, which is probably why I miss you. I need the rest of your name there. Delegate Krebs and Delegate Landis. Okay. Okay. The bill passes presumably with 8 in opposition and 16 in favor, since we're all still here. Okay, I assume the hands are up just as no votes, not as a you need to be recognized. Correct me if I'm wrong, please. Okay. Delegate Krebs, okay, good. All right, with that, we will move on, and I've completely lost the piece of paper. It's on the floor now. So Delegate Kelly, what's the number of the bill that we're moving on to?
1171.
1171, thank you for that. Erin, would you like to explain the bill, please?
House Bill 1171 is a proposed constitutional amendment, if approved by the voters at the next general election to be held in November 2022, that establishes as a central component of an individual's rights to liberty and equality, the fundamental right to reproductive liberty, which includes the right to make and effectuate decisions regarding the individual's own reproduction, including but not limited to the ability to prevent, continue, or end their pregnancy, and prohibits the state from directly or indirectly denying, burdening, or abridging a person's right to reproductive liberty unless justified by a compelling state interest achieved by the least restrictive means.
Delegate Kelly.
We don't have any amendments on the bill. It looks like we have some questions, though.
Okay, well, we'll start with Delegate Morgan, whose hand was up first. And then
Thank
we
you,
will
Madam
move on to
Chair.
Delegate Kinky.
Thank you, Madam Chair. And I want to thank the committee for just making this, debate among colleagues and civilized. And I do want to say what a touching story to Delegate Landis sharing that with us on the last bill. And while we're sharing some personal stories, because I know a couple delegates have done it, my girlfriend and I, we had a child out of wedlock when I was like 22 and she was 20. And I guess there was a choice, but in my mind, there wasn't much of a choice. So we call that child now Tyler. He's 26 and, great kid. So I wouldn't, I don't regret that decision at all. This bill brought forth by the speaker puts abortion in our state constitution. And to me, the state constitution and the reason why government exists in the first place is to secure freedoms. And it's just unusual that we're putting something in there. I know we're trying to change the language that secures reproductive freedom. But to me, this is really securing like ending a life. And Republicans or conservatives like myself, we value life, like Delegate Chisholm was talking about earlier. And I know what is causing some of this is, some Supreme Court justices were put on the bench. Texas law might have changed. So where my concern is really with this amendment, it looks like it's open-ended for abortions at any time, any place, period. I personally believe, and I think many conservatives believe, that life begins at conception. The Texas bill draws the line at 3 weeks. To me, the next logical step, if you're not going to agree with conception or 3 weeks, it's at least a viability of the baby. So currently, Maryland does have some limitations in their abortion laws at 24 weeks. And could we entertain an amendment to add that language into this constitutional amendment so we're not aborting babies that would otherwise be born alive?
So I can answer that question, Delegate Morgan, for you, because this came up at the hearing as well, and I wanted to make sure to have clarity on this issue. So the language of the speaker's amendment, it's very clear, right? We're going to support the right to make and effectuate decisions regarding the individual's own reproduction, including but not limited to the ability to prevent, continue, or end their pregnancy. And then it goes on to state, the state may not directly or indirectly deny, burden, or abridge the right unless justified by a compelling state interest achieved by the least restrictive means. And that, so really blurry all of a sudden, that language does allow us to maintain our existing abortion law. And that is the intention. Again, we just passed out of committee the Abortion Care Access Bill. There were some barriers in that bill that I don't think would have met this standard. The physician-only restriction would likely not meet that standard because there's no medical reason to have that on the books. The Medicaid funding being up for debate every year might not have met that standard. But the parental notice that we have on the books, the religious protections, and the existing language about allowing restrictions after viability does meet that standard. And I did consult the Attorney General's office and make sure that that was their interpretation as well.
Okay, so just a quick response on this. The Attorney General, I can name off about, I think there was 42 frivolous lawsuits against the Trump administration that he wasn't successful at any one of them. So I don't trust his public opinions. all the time.
And this is the AG's office, our AGs that we consult, not Brian Frosch himself. I
Right.
spoke with Kathy Rowe.
So they've been wrong in the past. I mean, obviously, this would probably end up in the court system at some point. I just think I think it would behoove the committee and many members if it was directly expressed in the same legislation. I think that would go a long ways. I appreciate you answering my question. Thank you, Madam Chair.
Thank you. Delegate Kaiser, will you be so kind and mute? Thank you so much. Next, I see Delegate Kipke.
Thank you, Madam Chairman. You know, I've been elected for 15 years, and this is one of the few times that, yeah, I feel a little sick about something that's passing through the House of Delegates. I just want to say that it's not necessary that we pass this bill, even if you want these kinds of protections, because no matter what happens with the Dobbs case.
Hold on one second, Delegate. So is someone unmuted? Will you be so kind? There's some cartoons or something in the background. And mute yourself. Thank you so much.
My fault. Thank you.
My pleasure. Delegate Kipke, I'm sorry. You can proceed.
It's okay. Thank you, Chairman. I do want to know what Robin Lewis is watching there. It sounded like a cartoon. So anyway, this Dobbs case isn't going to change anything in Maryland, period. It's not going to change a thing. So in my opinion, the only reason to pass a bill like this is to satisfy people that, in my opinion, you know, obviously have views that I don't share, but it's to take an extreme step in the direction of abortion that I really don't think most people appreciate. I don't think most people want abortion in the Constitution. We may disagree about what the different policies are around abortion, but there is zero chance that the state of Maryland is going to pass any bill that any delegate who's against abortion or wants to restrict abortion. There's zero chance any of that's ever going to pass here. And this Dobbs case just will not change the status of abortion in Maryland. So it's, in my opinion, it's an extreme step. It's unnecessary, and it just sort of makes me sick to have it makes me sick to have the word, you know, like marijuana in the Constitution too, by the way. So it's not just about, it makes me sick, the idea that we have gambling. We don't need to have these things in our Constitution. In my opinion, the Constitution is a broad document that speaks to the rights of Marylanders. But nevertheless, I understand that's the will of the committee to move this forward. Additionally, I do have concerns, you know, in the hearing, specific concerns. In the hearing, basically, we were told that, you know, lawsuits will determine the outcome of whether Maryland's laws and restrictions around abortion will be upheld. And, you know, I think it's unnecessary. I think it's these lawsuits that will be coming could take Maryland in an even worse direction as it relates to abortion. And for this and other reasons, I will be opposing the bill. Thank you, Chairman.
Thank you. We have next Delegate Brian Chisholm, and then I will give it back to the chairman.
Thank you, Madam Chair. And since Delegate Kipke was talking about it, I pride myself on knowing the U.S. Constitution and somewhat the Maryland Constitution. And the U.S. Constitution is pretty straightforward in what it says in the 14th Amendment. And it says, in the 14th, affirms that no person can be deprived of life, liberty, or property, and deliberately echoes the Declaration of Independence, proclamation that all are endowed by our Creator with the unalienable right to life. And then in the in the Maryland Constitution, it says the Declaration of Rights of the Constitution of Maryland likewise affirms the right to life and defers to the U.S. Constitution when state law conflicts. So to kind of piggyback on, because this is a legal question, really, or a constitutional question. I know we're talking about reproductive rights, but both in the U.S. Constitution and the Maryland Constitution, it protects the right to life. So the question now becomes, when do we recognize life? At what point do we recognize it in the pregnancy? Do we recognize it in the first trimester, the second trimester, or do we not recognize it until post-birth? I mean, that's a serious question. And without it being addressed in this bill, I have deep concerns about it. And, it's very disturbing. And once again, I echo what Delegate Kipke says. It makes me sick to my stomach that we are dealing with this, because I don't think it's going to change a whole lot other than to bring about an evil that none of us want to deal with.
Delegate Lewis Young.
Sorry, no, I didn't want to speak. Madam Chair.
I had my hand up.
Lewis
Thanks.
Young.
Oh, sorry.
Thank you. Thank you, Madam Chair. Actually, I wasn't going to speak to it, but I'd been thinking it all along. I do also want to reiterate my appreciation for this conversation being so respectful, because clearly the conversation is based on some really fundamental differences in values, and we're not going to change those today. When how we all define when a fetus becomes life, we're not going to resolve that. But so the issue is really different. Whether or not a woman has a right to choose, and to what extent we have an obligation to protect that. And I would say never say never. 2 years ago, I would have never thought there would be an insurrection and attack on Congress. So never say never. But I will reiterate my question from earlier, because I turned the page and realized that it is pertinent to the bill we are on now. And I do want to clarify that it refers to abortion only, because in her preamble, Erin made a comment about other related, and I didn't write it down. So I just wanted to make sure that this refers to abortion only.
I think, are you asking about what is in the language in the speaker's bill? It does not refer to abortion only. It actually refers to the ability to prevent, such as contraception, continue, such as choose birth and parenting, or end their pregnancy.
Okay, right. I phrased it incorrectly. That's what I was looking for. Thanks.
Yeah, the point of the amendment is that the state is not going to intervene in these decisions, which are very personal. Yeah.
Yeah. Well, I mean, because our conversation is focused on abortion, but it's referring to other decisions as well. Thank
Absolutely.
Delegate Krebs.
Thank you, Madam Chair. I guess on the last bill, there was a lot of talk about removing political debate on an issue for an issue. And I've told you many times, Madam Chair, that we have philosophical differences. The fact that we've turned this into a political debate, that one party's one way and one party's other, I think is really sad, because this is not one of those things that to me is political. It is moral. And it's a moral policy. And so let's just use the word philosophical and moral differences versus political, because that's sort of offensive to me. And it should be offensive to people on your side. And even on my side, there are people that agree that certain people should have access at early stages. And so there's differences. Someone's turned it into a political discussion, unfortunately. So one of the things that was mentioned on the last bill is that we have a fundamental right to reproductive freedom, and 92% would agree. And I agree that if you put that language there, that people are going to agree to that language. And I'm going to refer you to what's really offensive to me a lot is the actual words in what we're voting on. And it says Declaration of Rights. This will be in the Constitution, right to reproductive liberty. Who could be against that? That every person as a central component of the individual's rights to liberty and equality has a fundamental right to reproductive liberty, which includes the right to make and effectuate decisions regarding the individual's own reproductive, including but not limited to the ability to prevent, continue, and end their pregnancy. The state may not directly or indirectly deny, burden, or abridge the right unless justified by a compelling state interest achieved by the least restrictive means. That's the words that will be in the Declaration of Rights. And yet we've talked a lot and used the word abortion. And the word abortion means a lot different to people at any stage from conception to live birth. That's a lot different than what this says. And I think it's sort of misguided to think that people, I think if you read this language, they say, well, sure, people have the right to, they don't know really what that means. So if we really support the idea of abortion and a woman's right to choose, why would we not say it and use that word here so people know really what it is they're voting on? And I do believe that if you told people, there are people that are from one end of the spectrum to the other on this, but I think most people do not agree with late-term abortions or partial birth abortion. And that includes this in here. And so the further that you get on the spectrum, I think, and if you really tell it like it is, you would not have what you suggested would be 92% of a fundamental right to reproductive freedom, because the language, and now conception, we look at conception to viability. I think Texas, you said viability was 24 weeks. So I think that's problematic in just the language. And again, it's a moral and philosophical debate that we all feel very strongly about. The one thing that has not been mentioned, we keep talking about women making a moral and medical decision, and broadening access makes it less risky. Well, to date, we don't even keep data in Maryland, which we're one of only 3 or 4 states in the country doesn't even keep data on this stuff, which I don't understand why. That seems, well, anyway. But we haven't even talked about, we've been talking for what, hour and a half, we've never mentioned the unborn child. We've never mentioned this child whose life is being extinguished at any time. And we have a friend who's got a child right now born 3 days ago in Anne Arundel Medical Center that was born way premature. It's a tiny little thing. And I can't imagine that we don't even think about that child. And a few years ago, our committee, I don't know if any of you went, but our committee went down, more than a few years ago, we went down to University of Maryland Medical Center. And we went and visited school of nursing, and we went to downstairs where they were learning, and they had jars of fetuses every 1 month, 2 month, 3 month, 4 months, all the way to 9 months. Then we went upstairs to the neonatal NICU unit, and we saw babies that were teeny on tubes, and they were being taken care of. And I sat there and I said to myself, how is it that downstairs this is just someone's choice? It's a fetus in a jar, but upstairs, as soon as it passes through the birth canal, then we're going to do everything we can to keep this child alive, everything. And if somebody would snuff that life out as soon as it passed through the birth canal, then we'd be committing murder. But before that, and there's got to be somewhere to find some common ground on this issue. And so it's offensive to me, the language in here, that this is just somebody's choice and somebody's whatever, and it's reproductive. So just take it for what it is. But I think never mentioning the unborn child whose life is being extinguished in this is not helpful and honest to people. I do believe this is an extreme step to put it in the Constitution. We already have some of the broadest abortion rights in the whole country. I'm not proud of that, but that's where we are. Access, we already have funding, Medicaid funding for it. They might have to pay a copay and insurance, which to me, somehow this is a priority over other things. But I think it's an extreme step. And then other folks who keep saying, oh, because the Supreme Court may make a decision, it's going to stop all of this. And that is just untruthful. We all know that the Supreme Court decision, anyone that really wants to understand it, basically is going to send it back to the states, which is where I believe even Ruth Bader Ginsburg said the same thing. It probably should have been decided by the states all along. And that's all that will happen if the Supreme Court decision, so nothing would change. Our state, nothing would change. You say someday maybe it would change. I have no idea. I doubt it. But I think just have the conversation, be honest about the conversation. And I just think this language in this bill is so deceiving. And if you really support what you're saying, then put the words in there, put the word abortion in this Declaration of Rights, and let people know really what it is they're voting on. So obviously I'm voting no, but I just please call this not political, but call it philosophical and moral differences that really are important to many, many people. So thank you.
Thank you, Delegate Krebs. Delegate Hill, followed by Delegate Bagnall.
Thank you, Madam Chair. And thank you, colleagues. So I was going to start off just to make one statement, but I'm going to add something to it. Since people are sharing their personal stories, I'm not sure how many other people in our committee have had the personal experience of holding a 28-week-old preemie in their hand, performing the surgery, to alleviate the problems of a perforated bowel, have seen the child's heart stop on the table, personally performed CPR and brought the child back to life, and know that that child was alive a month later. But I've done that. Or some of you may have had the experience that I had of having a mother with adult children having a late life pregnancy that she and her husband and family took a while to decide they wanted to keep, who spent 4 months in bed rest to try and keep that baby, was brought into the hospital to be delivered the next day, just to lose that baby the night before. And then had to go down to the morgue to swaddle that cold body in a blanket and take the photograph, trying to make the child look alive so that the mother and her husband would have a memory of the child that they lost. So I want to say that all of us have stories to tell. And there, I suspect, is no one on this Zoom who doesn't consider these issues to be important and personal. That being said, I am not surprised, but I'm also heartbroken and sickened that we have come to the point where legislation like this, I believe, is necessary. Because I thought we had an in-between line that talked about viability, that balanced the rights of two living things. And I would no more have been in support of a state telling someone that they had to have a child or had to become pregnant than I would of a state telling someone that they were not allowed to become pregnant. And yet we have a history of forced sterilization in this country as well. State-sanctioned forced sterilization. So the fact that we're here now, as far as I'm concerned, that it has become political, is because for very good reasons, as they saw it, there are people who have felt that their opinion of my relationship with my God and how I understand and negotiate my faith is their business. So here we are, having this very difficult discussion. And as a pro-choice, pro-life woman of deep faith, I am glad that if this bill passes, it will go to the people. And the people will decide at the referendum whether they feel that state rights, which is what it's going to come down to, as opposed to equity for all women in their health care around all of these United States, but that if it comes to states' rights, it is the citizens of Maryland who will decide where Maryland stands. And that's all I wanted to say. Thank you.
Thank you, Delegate Hill. Delegate Bagnall.
Thank you, Madam Chair. And I really do appreciate everyone's comments. And I'm going to talk a little bit about why I think this is important. And I'm going to talk about question 6. And it's not that question 6. It's the other one. Because in 2012, I was very mad at this body because we passed marriage equality, but there was a little negotiation that left it open to negotiation, to further negotiation, to get a petition to get the question on the ballot. And I do not believe that civil rights should be up for debate. Civil rights should not alter when you cross county lines. They should not alter when you cross state lines. And the night before that vote, when it was put to the people, a very, very good friend of mine wrote an incredibly compelling post about how the voters who had no stake in the outcome were about to determine his future. They were about to decide whether or not his marriage to his partner was legitimate. And I was deeply, deeply impacted by that. So I don't love that we're putting this to the voters, but I think we're respecting our voters, because I do believe that this is the body that has to do the hard work. We have to take the hard votes. We have to make the hard decisions. And I think making the decision to put this to the voters, to codify a civil right into our state constitution is the right and moral choice. And I do understand that we have philosophical and moral differences. I agree with Delegate Krebs, but I don't think that there is one correct moral choice in this debate. So for that reason, I am supporting this this legislation, and I do have a question for whoever can answer. Have we heard of people in Maryland who are concerned about losing their rights?
I can probably answer, because I have heard quite a bit from a number of people in the state of Maryland. This legislation before us was not introduced for no reason, right? It was introduced because there has been a tremendous amount of concern, some of which we've already heard expressed today from our colleagues, about what is happening in the country, what is happening in our neighboring states in the context of the Supreme Court, and where that will leave Maryland, and potentially what could happen in Maryland in the future. We do know, you referred to the previous question 6, that the voters in Maryland already did vote to codify the protections of Roe versus Wade 30 years ago in that referendum. But we know that today people are concerned and they need that protection elevated. That's the point of this legislation, to give the voters another opportunity to say, we believe in these fundamental rights. We want them embedded in our Constitution so that they cannot be easily rolled back.
Thank you very much.
Delegate Riley is next.
Thank you, Madam Chair. Yes, I have a question. So what I'm hearing, okay, you want this to be on the ballot. So if this particular bill fails at the ballot box, does that automatically make HB 937 null and void because the people do not want it?
There's no relationship. HB 937 is a statute. It's removing a couple of barriers that are currently in place in our existing policy, but otherwise keeping the policy that was voted on by the voters in 1991 in place. This bill is unrelated. This is a constitutional amendment establishing this broad reproductive liberty as a right.
So you're saying that you wouldn't even consider that, knowing that the citizens have voted and that they don't agree with aborting babies, you know, as we currently do, and as we're even broadening even more with HB 397, that you wouldn't consider amending that some way or changing it after the voters have voted?
I think there could be a lot of reasons why people vote a certain way on a constitutional amendment as they read the language. I think it is highly unlikely that the voters would read this and conclude that they do not want that. But should that be the case, there could be a million reasons why it's not. The question is not giving them the opportunity to affirmatively say, no, I want a ban on abortion in Maryland.
Okay. Thank you very much.
Delegate Saab, followed by Delegate Kaiser.
Thank you, Madam Chairman. So obviously a lot have been said tonight. Obviously, you know where I'm at on the abortion issue, and as Marylanders, we have a lot to be proud of, a lot, but not today, not when we have bills like this that goes on the floor that are purely political, that we all know. We can sit here all night and debate pro-life, pro-choice, be both at the same time. And then we can debate, you know, morals and civil rights of but one thing we're forgetting, that we keep ignoring that this is a life. This is a person. All of us were that life at some point, and had our parents made the choice, we wouldn't be here today. So I honestly, I'm disappointed, and I understand, you know, being in the minority party is not fun at all. And we get bullied a lot on a lot of different things. And it's just ironic that, you know, obviously it's election year, but this is all about driving people to the polls. This isn't about rights. And I'm just disappointed that we're going to have this. Obviously, it's going to pass committee. We don't have the votes to stop it. It's going to go on the floor, and it's going to pass the floor. But to Delegate Krebs' point, at least if we're going to be honest with ourselves, at least give the voters the right language so they know exactly what they're voting on. So I hope something will be reconsidered with the language, because I think it's very important that we do not mislead the citizens of Maryland of what this amendment or what this constitutional amendment is about. Thank you.
Thank you, Delegate Saab. Delegate Kaiser. And this looks like the last hand before me. If anybody else has anything to add, you need to get a hand up. Delegate Kaiser.
Thank you, Madam Chair. I had a few things to say. I also wanted to respond to a few things I heard about, you know, whether if our parents had had this choice, where would we be? But I also think that life is a beautiful choice, and that's a choice that our parents did make, and I look at it that way. I've also heard a lot about our state constitution and its how beautiful it is. But you know, if you look it up, if you Google it real quick, the U.S. Constitution is over 4,500 words. Our Maryland state constitution has 47,000 words. I wish that off-street parking wasn't mentioned in our state constitution, for all of those of you who've read the whole state constitution. On the issue itself, I like to point out a simple fact that, to me, the alternative to a safe legal abortion is nothing short of the government forcing a woman to carry an unintended pregnancy to term. And to repeat that, those opposed to abortion are in support of empowering the government to carry those unwanted pregnancies to term. And it always surprises me that the same people who think that the government is too big and too powerful and too much in our lives would want the authority to force women to carry pregnancies to term. But if we do that, let's also be clear that we should ensure that every single woman who's forced to carry her pregnancy to term is provided with adequate prenatal health care, and that those children born from these pregnancies can also get health care and a vast amount of community support, which we all know is very expensive and would most certainly increase all of our taxes. But I also want to say that as a mother, I'm a strong supporter of women's right to privacy, but yet it's sad that abortions have to occur. And I think that's one of the places we all can agree, and that we can't, I'm not sure why we can't find the middle ground by preventing unintended pregnancy with expansion of contraception options and age-appropriate sex education. But seemingly the people who oppose abortion also oppose contraception. And so here we find ourselves today. Ultimately, Madam Chair, I think abortion should be safe, legal, and rare. And I think the right to choice should be protected and enshrined in our state constitution. And I thank Delegate Kelly for all the work she's done on this.
Thank you, Delegate Kaiser. Delegate Morgan.
If abortion is going to be safe, legal, and rare, I don't think it should be performed by anyone at any place at any time and then at taxpayers' expense. Look, we've had a really decent debate. I don't know why we're getting into the morals of what other people are that they actually have, but I think the last speech was a little bit offensive. We care about the life of the baby. I know of no government in the United States, not a single state, that is saying, hey, we're going to make a woman force a woman to carry a baby. That's a choice. What state actually does that? And if we're going to actually put this in our state constitution, what's the holdup from putting some clear, defined language? I'm looking at this. The word abortion does not even appear in this whole written text. What is the problem with putting clear language in there that says abortion? That's all. Thank you.
Thank you, Delegate Morgan. Delegate Hill.
Thank you. And since we're not going to be able to have this debate on the floor, let me just say that when a state passes a law that makes it illegal to not only seek an abortion, not only to perform an abortion, but to assist in any way, including being the Uber driver, to take the person to an abortion, allows anyone in the state to, or outside of the state, to bring civil charges for damages. Yeah, that to me sounds about as close to forcing someone to carry through with a pregnancy as I can begin to imagine being done in any totalitarian state. So I don't think that's a far-fetched idea. I also don't think this is about abortion solely. It is about autonomy over one's own body and health choices, just as the state staying out of Terry Schiavo's, being on life support, and members of Congress deciding that they would insinuate themselves between her husband and the medical providers and her because of, I guess it wasn't the politics, it must have been morality. Yeah, that was problematic for me too. And I do believe that if we want abortions to be safe and rare, that we have to have a society that, adequately deals with spousal abuse, forced rape. Well, forced rape, that's redundant, isn't it? Rape, sexual assault, gives the kind of social supports that Delegate Kaiser spoke about, that makes sure that every child that is born is cared for and loved. And I know everyone on this committee does what they can to make sure that people who perpetuate crimes against children are, punished. And we try, all of us, to make a society that's better for our kids. But that's not the fantasy society we live in. The society we live in is one where mistakes happen. People absolutely are sometimes just cavalier and unthoughtful and treat abortion like having a drink on a Saturday night, men and women. But it's not, in my opinion, our place to get in the middle of their morality and how they relate to their God if they believe in one. And yes, a fetus is a unique entity in our society. because so much of its being able to come into the world is dependent on the health of a carrier. So it is impossible to look at this issue and pretend it's the same as any other issue when we're talking about the rights of one party and another. And we all know that. And I think we need to be honest about this. This is not a clean issue, which is another reason for me why the civil rights issue is so important. Because in the end, the people who have to deal with these decisions ought to be the people who are going to have to live with them. And if we all want to do our best, we will continue to do the things that support women in troubled pregnancies so that they can make the decisions that so many of you have made to try and carry to term. But that should be their decision if the voters of Maryland agree that their civil rights include autonomy over their own health care, and that includes their sexual health and their reproductive health.
Thank you, Delegate Hill. Delegate Chisholm.
Thank you, Madam Chair. Just a quick statement. And to Delegate Hill's point, rape and incest, we all understand, is evil as well. And maybe there are exceptions, but there's also another way to look at it. You know, we have red lights that oftentimes police and emergency medical vehicles have to go through. And it's an exception. It does not mean we rip down all the red lights. And that's what we're doing here. We just want to rip down all the red lights. I feel for anybody that deals with the evil that you just mentioned, but it's not all the same. Thank you, Madam Chair.
Thank you, Delegate Chisholm. And the last word, unless the floor leader of the bill wants to say something, will be Delegate Peña-Melnick.
Thank you, Madam Chairman, and I'm going to keep it really short and simple. I want to thank everyone for a very respectful debate, and I respect all of you. Just like our 5 fingers, you know, they're all very different, they're not the same. We all come from different backgrounds with different values, with different principles, with different experiences. Myself, as someone that grew up in a very religious family, through the years, I came to this conclusion where I wasn't there when I was younger, but I did as I read, as I met people in college, as I saw those struggles, that, you know, a woman can decide for herself if and when, with whom to start or grow a family. I will be voting for this bill because this is a personal choice that I know and understand that not everyone will avail themselves when we pass this bill. But that if a woman needs to avail herself, that we in Maryland give her the choice to do that and to do it in a safe manner. Thank you, Madam Chairman.
Thank you, Delegate Peña-Melnick. Did you have anything you felt needed to be added to this, Delegate Kelly?
I would just really very much like to repeat what the Vice Chair said. I appreciate the respectful debate. I appreciate this committee very much. These are challenging issues. I would like to just clarify, because I know there was some concern that the language wasn't clear, but the language in the amendment clearly says, you know, end their pregnancy, which I think people know what that means. It means end the pregnancy. So I wanted to make that point of clarification, but other than that, just really make the point that we all have the right and the opportunity to have our own beliefs about this. We live in a pluralistic society, which is a beautiful thing. And we have different beliefs and different moral values and different life experiences. And we are not, through this legislation, making anyone's choice for them. And that's incredibly important, right? We are respecting individuals' ability to make their own choices. Any person who can get pregnant is still a person and has their own emotional, spiritual, moral belief system and their own context in which they're making these decisions. While I can hear how so many people on this committee feel very strongly about this issue on both sides, I just want to really reiterate that this is just an amendment, a constitutional amendment that is going to the voters, and they will be able to have their voices heard on this. And whatever they choose, I'm going to assume they're going to choose to support this amendment, because ultimately this amendment is choosing to not make anyone else's decision for them. And that gives us all the ability to respect each other as individuals in a pluralistic society. So that's the only point that I would make. And again, thank the committee for demonstrating the fact that we can respect each other as individuals in a pluralistic society when we have different opinions on this issue.
And we have moved and seconded this bill, haven't we? And there are no amendments. So I am going to ask all those in favor to please say aye, and all those opposed to please raise your hands.
Aye.
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 I'm going to read the noes. Oh, that Kipke hand is very hard to see. I'll look in the column. I've got Shalega, Delegate Chisholm, Delegate Saab. Nice to see that. Delegate Krebs, Delegate Kipke, Delegate Morgan, Delegate Riley. 1, 2, 3, 4, 5, 6, 7. If I've missed anyone, please be clear. So the vote is 19. That can't be right. Must be 17 to 7. Thank you very much. That does work. And this bill passes and will proceed to the floor. And I would be remiss if I didn't tell you how grateful I am to all of you and how much I respect every one of you. And I look forward to doing all the things that we can, all with the best intentions for the citizens of Maryland. And with that, I hope you have a nice evening, and again, thank you. And we will stand adjourned, and I will see you all on Monday. Don't forget, we're meeting on Monday next week.
And may I make an announcement? The public health, please, thank you, Chairman. The Public Health Subcommittee, due to no fault of our own here, it's actually meeting at noon on Monday, and for the next 2 Mondays at noon, and then we're going to 4 o'clock, and I apologize because now we're on the floor at 6 o'clock. So please understand, and I hope you have a wonderful weekend, okay? Thank you, Chairman.
Thank you. All right, that ends our work for the evening. Good night, everyone.